we say there are very small needles, but still it's painful. And the biggest worry of patients is not the pathogens of diabetes mellitus, nothing like that. It is only the fear about insulin injection. That is the one that is that is the most important problem for the patients. And living with diabetes mellitus is not a very simple thing, especially type 1 diabetes mellitus. You can see here, you have to inject around 3,300 injections per year if you are going as per basal bolus insulin therapy. So one basal injection is 365 injections, 3 bolus injection is around 1,095 injections, and total monitoring around 3 or 4 times daily, around 1,800 pricks. So total they are pricking themselves around 3,500 times per year, which is not a very silly thing as what we think it is. So previously insulin delivery was with syringes. So syringes, but it is painful. But still, as we have evolved over time, the technology has improved. Syringes has become disposable. So previously, you can see the big ones on the left-hand side. The big injections, which will definitely be painful. It will be having lower gauge and the thicker, wider needles you can see on the left side. But on the right side, you can see the needle size. The gauge has increased, and the needle size has come down. Even the length has come down from now even 4 millimeter length needles are available. So this is what has evolved over time. And syringes are suitable for free mixing of insulin and requires manual dexterity and visual acuity. And one thing as in practice that you should always discourage the patient is that don't allow them to change between 40 units and 100 IU syringes and needles. So they are different. Some patients from Gulf, they will bring 100 unit syringes, plenty of 100 unit syringes, and they will use the 40 units vial, which is available in India, and they will inject. That will make confusion. So never allow them to use 100 unit syringes for 40 units vials. This always happens. That's why I'm giving some practical tips. So that is one problem that happens. So syringes have got lower compliance, less accurate dosing, more injection pain, and even trained nurses can make dosage errors. So what happened to this person who presented to me around 15 years back is that he was started on basal bolus regimen with the insulin syringes at that time because pens were not widely available. So he again landed up in diabetic ketoacidosis after 3 years. Because he was depressed due to pain of insulin, he used to miss insulin, and there is some kind of a problem with prolonged insulin usage. Any idea? It is lipohypertrophy. So if you inject insulin to the same site, what can happen, especially with the larger needles, what can happen is there can lipohypertrophy can happen and insulin will not work. So a person landed up again in lipohypertrophy, and at the time of discharge, so initially he was in DK, then due to lipohypertrophy and missing of insulin, he again landed up in DK, and then he was started on basal bolus regimen. It's kind of a regimen which gives better glycemic control, and he was started on insulin pens. So at this point of time, just 1 minute on different insulin types that is available as of now. Short-acting insulin, I think all of you will be knowing, it is regular insulin. Is the usual short-acting insulin, but rapid-acting insulin or insulin analogs are Lispro, aspartame, glulysin. They start acting very fast. And the latest ones are ultra-fast-acting insulin, which acts extremely fast is Fiasp, that is rapid-acting aspart. That is the ultra-fast-acting insulin. Then intermediate-acting or insulin includes the previous NPH insulin, which is an intermediate-acting insulin. But nowadays we have Glargine, U100, which is the time-tested molecule for long-acting basal insulin coverage. Then there is Detimir, and longer-acting insulin like Degludec or U300 Glargine is there. Then the most common insulin that we use in our practice previous years is premixed insulin. That is a combination of regular and NPH insulin. So if it is 30-70 human mixture or something like that, which is very commonly used, that's why I'm telling the name, the trade name and everything, human mixture, human insulin 30-70 and everything, they contain 30% of regular insulin and 70% of NPH insulin. That's the composition. So that both fasting as well as postprandial components are taken care. And there is a aspart mix, there is a rapid acting insulin analogs plus NPH is there. Then Lispro mix, there is Lispro is an analog plus NPH is there. And latest addition to the insulin armamentarium is Rysodec, which is a co-formulation. Co-formulation means it is an analog co-formulation. There is a short-acting insulin analog known as aspart and a long-acting insulin analog known as Degludec. They are put together in a percentage of 25 versus 75, that is known as Rysodec, which is supposed to have less hypoglycemias. And this again and is another slide. I think it's very difficult to very difficult to imbibe all these things together. But still, short-acting insulin starts acting very fast, which is the usual one which is given in any hospital and everything. Regular insulin, or previously used to be called as plain insulin. They act fast within 0.5 to 1 hours, and usual duration is around 4 to 6 hours. And NPH is a insulin which we used to give at bedtime, or it is a component of premixed insulin as well. It starts within 2 to 4 hours, and duration is usually maximum less than 20 hours. So lente insulin we are not using anymore. Ultra lente is also we are not using anymore. Premixed insulin I told already, it's a combination. And regarding the newer insulins, the point is that if you are giving the newer rapid acting insulin analogs are Lispro, Aspart and Glulysin. So they have to, the advantage of the rapid acting insulin analogs is that they can be injected just before meals. So for example, a person is there even in hospital settings, person who is having some kind of nausea or any vomiting or tired, person is not able to take orally properly, you can even give the rapid acting insulin analogs after food also. So that's the advantage. Previously always we say that insulin has to be taken before meals, but this kind of insulin analogs like Aspart or Degludec, not Degludec, Aspart or or rapid acting Aspart, you can just take after meals as well. Then long acting insulins are usually given at bedtime. Glargine given at 10 p.m. Usually they are given at bedtime. Glargine duration of action is around 24 hours. So if you are giving injection Glargine at 10 p.m. tonight, the action is likely to persist till 10 p.m. tomorrow. Detimir again up to 24 hours is the action. Degludec is a very long acting insulin with less chance of hypoglycemia. Is otherwise known as Tresiba. It is active for around 3 to 7 days, but usually it acts for 24 hours. Is the half-life. And premixed insulin I told they include both the rapid acting insulin and premixed insulin. So one thing that we don't follow nowadays is the basal insulin therapy. So I will just discuss something about basal insulin therapy. So previously when we start insulin, the only thing that we come to our mind is premixed insulin, like Mixtard or human insulin 3070 or something like that. But basal insulin therapy is one of the best insulin therapies that you can resort to in the early phase of diabetes mellitus, especially when the patient is requiring insulin. So the basal insulin therapy, the main drugs for basal insulin therapy is Glargine, Degludec, which is a long-acting insulin analog, or a U300 Glargine, which is a newer addition. So what is Glargine doing? Glargine is a clean insulin at a pH of around 4, which is usually given at chance of the patient going to hypoglycemia is significantly less if you are giving basal insulin at bedtime. So that is the advantage, but still hypoglycemia is there, but the chance is extremely less. It is the most widely used basal insulin. There are so many biosimilars as well for U100 Glargine. The original one is Lantus, then there is Basaglar, Basalog, Basugin. So many brands are there for the basal insulin. It is given at bedtime, targets fasting glucose, and the hypoglycemia is much less. So once you target the fasting glucose and makes it around 80 to 100 or 90 to 110, it's very easy to control the PP sugars by dietary modification or by adding gliptins or by adding another insulin in the morning time before breakfast or something like Apidra, like Glulysin, Aspart or short-acting insulin analog. So basal insulin therapy, I think all of us should be aware. It is an insulin therapy which is much safer than giving a premixed insulin in the beginning stage of diabetes mellitus. Because it controls the fasting glucose extremely well when compared to premixed insulin therapy. So this person was started on basal bolus insulin therapy. That means basal insulin at 10 p.m. and bolus insulin before meals, because it's a type 1 diabetes mellitus. The best insulin therapy is basal bolus therapy. So he was started on basal bolus insulin therapy using insulin pens. Insulin pen devices are extremely convenient for the patient, and they are compared to syringes. The inconvenience of carrying, syringes carrying is very difficult. It's so many things have to be carried. The vial has to be carried, syringes have to be carried, and the wiping part, the alcohol, the swab, everything has to be carried. But here you can just carry the pen. Then the psychological impact is much less, and the pen have got greater accuracy, convenience, patient preference as well as adherence by the patients. And if you are using an insulin pen, there are very few steps. But if you are using a syringe, there are many steps like drawing insulin and mixing and everything is there. But here it is very convenient for the patient. Resuspend insulin if required, attach new needle and inject. Less injection force is there, less pain is there. So it's pretty easy for the patient to deliver insulin by using a insulin pen device. And adherence by the patients is also more if you are giving insulin pen when compared to insulin syringes. There are some studies comparing insulin pens and syringes, and you can see that definitely patients are more adherent to insulin pens. It is not, so sometimes some patient might come and ask you, so doctor, I want to shift from insulin syringe to insulin pen. What is the dose conversion? So what will you say? There is no dose conversion. It's the same unit that we are injecting. So insulin pen or syringes, it's only the mode of delivery which changes. There is no change in dosage. So that is one point. And accuracy is more if you are injecting insulin pens when compared to insulin syringes. You can see the amount of insulin being delivered is more if you are using insulin syringe pens. So you can, if you are delivering 10 units, around 9.74 will be delivered if you are using syringes. So that is a maximum that you can get, and better HbA1c if you are using insulin pens when compared to insulin syringes, and lower hypoglycemic episodes as well if you are using insulin pens when compared to syringes. And nowadays it is a the insulin, better quality insulin pens are available, which are accurate in dosage, convenient, which are durable and which are safe as well. And there is an end of dose click is there which will suit the patient much better. And how to get the best out of an insulin pen is it should be primed before use. That means you should see the at the tip of the insulin needle, you should see a drop before injecting. That's priming. It's a single person use. Dispose the needle even after single use. That is what is usually said, but nowadays we use 3 to 4 injections. Needle only once. Thumb button to be pressed only after fully inserting the needle. Count 1 to 10, but usually you should count it 1 to 10 and then withdraw the needle. And pressure should be maintained until the needle is completely withdrawn. See, these are some practical tips to get the best out of pen. So my patient was initially who landed up in DKM was started on injection, insulin infusion, then started on insulin syringes, was then started on insulin pens, and he was actually living very happily with the insulin pen. He was very happy. So he decided to go for a tour to Himalayas, and he was doing the injection, but he landed up in DK again. Any reason you can think about why he landed up in DK again? So it is basically the temperature and storage that is a problem. So insulin should be stored at 2 degree to 8 degrees Celsius, but here Himalayas it was some kind of minus storage, and it was broken. The cartridge was broken. So if you are storing below 0 degree, it may lead to product being frozen, causing cracking of vials and some kind of problems. And temperatures during transportation is also important. It's 2 to 8 degrees Celsius, and never leave the needle attached to the pen after usage. Always remove the needle. So these are some practical points that I want to highlight because of this in this mixed crowd. That's what I'm doing. So never leave the needle attached to the pen. That is one point. And storage, humidity, no special requirements. Light, protect insulin products from direct sunlight and strong artificial light. Wet condition, protect insulin products from wet conditions such as rain and snow. So stability, this is one point that so once you are having a person who is a senior person in your house is asking you how much days we can keep the insulin outside the fridge. So if the cartridge that is just opened, you can keep up to usually 42 days with the newer insulin like Glargine or something, those kind of insulin up to 48 days. But usually 28 days we can keep it even outside the fridge in room temperature, less than 30. Usually the aspartame, those kind of things are around 28 days, but premixed insulin is around 10 to 12 days. You can keep it outside in room temperature, not in hot condition, room temperature. The used cartridges you can keep. This is what the stability once opened is for these many days. So at 23 years, now he has grown up. My child has grown up. He is working in an IT firm and he is earning a good salary, and he is Googling. And he is asking me what are any newer advantages, and now I told him that there are some kind of smart insulin pens in which you also get the insulin glucometer recordings can be combined with the insulin pens. And he was again asking me whether inhaled insulin. So that is one of the things, because they can avoid the prick. But inhaled insulin, as of now, it is not available. It may get launched next year or something like that. And it is not very popular, even in Western countries where it is available. It's known as Afresa. and it is a bolus insulin, which can be given as inhaled insulin, but basal insulin you have to continue. So just some points, and there are some pellets. One pellet will have 4 units in it. So that is the inhaled insulin. So at 25 years of age, so he is evolving in time. He has learned a lot, and he was asking me about insulin pump. So doctor, what is your opinion about insulin pump? And his HbA1c is around 9 with occasional hypoglycemia. So what about insulin pump? So insulin pump is nothing like a medicine or something. It's kind of an insulin delivery device only. So it's very easy to make micro dose adjustment. Flexibility of time is there. No pricks. That is the most important thing for this particular patient. There is no prick involved except for SMBG monitoring. That is also not nowadays it has come down. No pricks. It's more physiological and less hypoglycemia. Better glycemic control is not assured. So some kind of VIP patients or very rich patients with type 2 diabetes mellitus will come and ask me. Their HbA1c will not be, their food habits will be very bad, and they will not be taking insulin properly, and their HbA1c will be 10 or 11, but still they will tell that I would like to go for insulin pump. Insulin pump is not for those kind of patients. Insulin pump is to be reserved for those patients who will be probably type 1 diabetes mellitus with mixed glycemic variability. For every diabetic patients, because they are very rich and everything, you cannot go for insulin pump. That is not recommended, and there is no benefit of insulin pump for over the usual conventional therapies in type 2 diabetes mellitus. The fairly controlled type 2 diabetes mellitus, there is no indication to go for insulin pump therapy. I think it should be reserved for, especially for type 1 diabetes mellitus with the, and also with the mixed glycemic variability patients and pancreatic diabetes. So many indications are there for insulin pump. So there are some advantages, and there are so many variables. Insulin pump, size of reservoir, size and type of screen, basal bolus increments, and compatibility with the glucometers, ease of program. I think these are points I need not discuss. But insulin pump is also not the final answer, because insulin pump site selection can be problem, and even lipohypertrophy at the insulin pump sites, insulin pump breakage can happen in the reservoir as well as in the flow, and diabetic ketoacidosis due to pump failure can happen, and pump non-affordability due to high cost. That is another thing. Especially on the right side, it is very clear that high cost is prohibitive factor for insulin pump for every type 1 diabetes mellitus patient. There are even trials like REPOSE trial, which compared insulin pump with the typical basal bolus therapy in type 1 diabetes mellitus, which showed that there is no difference in percent of subjects reaching HbA1c target to less than 7.5 if you are using pump or basal bolus therapy. So that may not be hugely different if you are using insulin pump of older types. And he was started on continuous subcutaneous insulin infusion, otherwise known as insulin pump therapy. He used to do 5 pricks a day and adjust bolus dose. And for this patient, his HbA1c has come down to 7.4 after 3 months. And in 2021, so I am coming to the newer updates for insulin therapy. So 2021, he has become a CEO of an IT company. He is very busy, and he forgets to do a SMBG. He is not able to do the glucometer monitoring, and he is a frequent flyer as well. And he has got erratic food habits. And is there any kind of artificial pancreas which autocorrects for my sugar peaks? This is what he is asking. So what I should tell is regarding the newer development of the artificial pancreas system. So in 1920s, insulin was discovered, and then there came the sub-Q insulin pump, sensor augmented pump came, and nowadays we have got the 780G insulin pump, which is an artificial pancreas, almost like an artificial pancreas. And the key features of sensor augmented pump and artificial pancreas system is that you can see on the extreme right-hand side. I think that is the important thing. Automatically determines basal insulin dose infusion rate all day, and with user-initiated mealtime bolus. And the patient has to just tell the pump or just dial how much food he has taken. That's enough. So that's all. And with automated correction base. So even if the sugars go up, it will correct. If the sugars go down, it will even shut off. So it's almost like an artificial pancreas. So a pancreas which is there outside the body. So that's all. So this is the 780G. So it's almost like, it's not 100%, I will not say it's 100%, but almost like 90% of the pancreatic functions will be done by this kind of insulin pump. But it's prohibitively costly, but worth the cost. So this person was started on 780G. My patient was started on 780G Minimed, which is the artificial pancreas. He just counts carbohydrates and enters the values. With the help of artificial intelligence, the pump pushes the correct bolus. There is no need for any external dose correction, dose calculation and everything. So even if he forgets, that is okay. For type 1 diabetes mellitus, the pump injects correction bolus by smart guard technology. There is some kind of a smart guard technology, and there is no hypos, because hypos it will shut off. So that is a newer insulin pump, and I think this is again a complex slide which shows how it is regulated. There is a glucometer, or there is a continuous glucose monitor along with this kind of insulin pump. It can be connected to the laptop, and even the care provider can see it through the cloud-based apps. So even if my patient of Mr. V, I can now see what's the sugar value the patient is having, and how he is doing. We can assess through the cloud-based one for this artificial pancreas. So this is what Mr. V is doing now, and you can see over time how the glycemic ranges have improved. The time in range is a new concept, I think. That is another topic of topic itself. So time in range has improved to more than 70%. So if you are having a time in range, sugar values of more than 70, it is said that your sugars are well controlled. So this is a new metrics of my patient Mr. V. He is having no hypoglycemia. This is the ambulatory AGM read, or the continuous glucometer reading, which shows that 0 means no hypoglycemias. 75% of the time he is normal, he is having normal sugars, and around 20% of the time he is having slightly above, but that is acceptable in type 1 diabetes mellitus, and he is not having any hypos. That is the biggest advantage. No hypos and mild elevation, and so almost 75 to 80% of the time sugars are well controlled with this kind of insulin pump, which is a artificial pancreas. And now he is on insulin. He is very well controlled and extremely happy as well. And he is asking me whether any future direction of insulin therapy is coming to me. So then I answered him. There is a kind of insulin therapy known as ICODAC, which is a long-acting insulin analog, which is coming after 1 year to India. It's almost launched in Western world. So it's only a basal insulin. So it has strong reversible and albumin-binding properties, along with reduced insulin receptor binding affinity, inactive circulating albumin-bound depot from which ICODAC is slowly consistently released, and its half-life is 1 week. So it can act up to 3 to 4 weeks, but usually given it as one injection. It is compared to glargine in type 2 diabetes mellitus, and you can see that compared to glargine, it produces similar glycemic control, or even better glycemic control with less hypoglycemias. So better glycemic control with the long-acting insulin, that is once weekly insulin, which is getting launched in India by next year. So that is what is there for the future insulin therapy. So what I wanted to highlight in the past 20 minutes is that insulin delivery systems include vials and syringes, insulin pens, insulin pumps, sensor augmented insulin pumps, and closed loop system, which is the artificial pancreas. So that is the latest armamentarium, and the once weekly insulin is also coming up. Aim of therapy is the simple aim of therapy is to achieve glycemic control. So by whatever means, without hypoglycemias, because hypoglycemias probably is a silent killer. So if you are having a person in your house with a sugar value of 30 or 40, the chance of mortality is significantly high. But if you are having a person of sugar of 300 or 400, immediate mortality is not there. So definitely hypoglycemia is more dangerous than hyperglycemia, and hypoglycemia should be avoided at any cost. So newer developments in the insulin therapy are mainly aiming at achieving glycemic targets without hypoglycemias. It is not that NPH insulin is inferior to glargine in potency. Potency wise, usual NPH insulin is equal to glargine, there is no doubt. But what glargine is doing, glargine is better than NPH insulin as far as safety is concerned, hypoglycemia is concerned. Hypoglycemia is less than NPH insulin for glargine. So that is what we are doing, and basal insulin therapy and basal bolus insulin therapy are better than conventional premixed insulin therapy because chance of hypoglycemia is less, and cost is a barrier definitely for whatever I told, for the newer insulin like ICODAC or the artificial pancreas, or even the degludec, or ultra fast acting insulin analogs, or even glargine is costlier than NPH. So cost is a barrier as the technology advances towards automation. So with that, I would like to wind up the story of my boy. Thank you so much for your patient listening. Thank you.
Thank you, Dr. Vimal, for taking us through the journey of development of insulins and other important development of management of diabetes through the journey of Master V. I think it was a wonderful one. Any questions or comments?
So the use of insulin pumps, what is your experience in the Kerala experience, your experience in instruments? Do you have people coming to you, asking you?
I got around 15 to 20 patients on insulin pumps actually. So mainly what I do is I recommend insulin pump therapy only for patients with type 1 diabetes mellitus, because type 2 diabetes mellitus most often we can control insulin diabetes mellitus with drugs usually, with the diet and exercise. But type 1 diabetes mellitus is extremely variable and glycemic variability is there, and it is mainly in type 1 diabetes mellitus or pancreatic diabetes that I recommend type 1 diabetes mellitus. And there are some patients, very affluent patients who come to me with type 2 diabetes mellitus. What I do is I usually discourage them because they won't get the, because they are just they just come for showing off that they are affordable. So type 2 diabetes mellitus, usual routine type 2, there is no indication as such, unless the person is having a severe mixed glycemic variability or severe nocturnal hypoglycemia, so something like that. You can talk about insulin therapy pump. It can be given to type 2 diabetes mellitus as well. I'm not saying that I'm against, but there are some reserved indications for type 2 diabetes mellitus on insulin therapy. But the person who will benefit the most is type 1 diabetes mellitus. My all patients are, almost one patient only is type 2 because he was having mixed glycemic variability. All the other rest are type 1 diabetes mellitus. Around 14 patients are on type 1 diabetes mellitus and 4 patients on the 780G system, the artificial pancreas, around 4 patients. And all these 4 patients are doing extremely well. They are having a time in range of around 100% in 2 patients. Every time the sugars are normal for artificial pancreas. So that is the advantage of artificial pancreas, but they are prohibitively costly, that I admit. But that is one step towards almost like it's a pancreas transplantation. That's what I would like to tell.
Any other questions or comments? So thank you, Dr. Vimal, for this wonderful lecture, and I hand over the proceeding to the organizers.
I request Pradeep sir to hand over the memento to Dr. Vimal. I call upon Dr. Jayachandran, Department of Medicine, Government Medical College, Kozhikode, to chair the next session.
Good morning. We are going to have another important session, and this is on hand surgery. As you know, hand surgery is one of the highly advanced field of surgery. I'm not a surgeon, but we know that it's a very important thing also. And a lot of new developments are happening in the field of hand surgery. And there are many patients who go on with deformities. Like as a rheumatologist, we see patients with lot of small deformities, and most of the time these deformities are not given due attention, and doctors generally don't give any attention to that. But patients are very much worried about these deformities, even small deformities happening in the fingers. To the patient, it is very, very difficult, and they ask about any possibility of correcting these things, and hand surgery is a field where they can do a lot of things in this. And to talk on this, we have Dr. Febin. He's the consultant hand surgeon from Maitra Hospital. I think he's... I welcome Dr. Febin to the dais.
Good morning. Good morning, sir. Good morning, one and all. Here, my responsibility to talk on hand surgery. So, I'll slowly start with a quote. It is in your hands to create a better world for all who lived in it. So, moving on, before starting with hand surgery, I'll just have a small introduction about my unit. We are basically we all are orthopedic surgeons, and we are of 12 members, and out of which hand surgery has been subdivided into 3 people, and we subdivided, and we are of 3 people. And Dr. Gopalakrishnan, who is our HOD, and myself and Dr. Amish Roy. So today we'll discuss about few cases which we have done in our unit. So first one is an 18-year-old boy who is a college student who had alleged history of RTA, following which he lost his 4 fingers except his thumb. So it was a complete amputation. This is a diagrammatic representation. Following which we had done replant was done for this patient for 4 fingers, out of which his 3 fingers was viable and 1 finger was not viable. And we had given him an option of 3 options. One is artificial finger or ray amputation with an artificial finger. And then last option was a toe transfer, which basically is a second toe will be transferred to his middle finger. So he opted for the toe transfer. So this is the final outcome, like following replant surgery. So in this picture, we can see there are 3 fingers are viable, and out of which middle finger is lost. So we had planned him to get his second toe. So initially we had measured the middle finger of the opposite hand, out of which it was 9 centimeter. And this last finger, the final part of this metacarpal for proximal phalanx, the distal part was only 3 centimeter. And we require mainly 6.2 centimeter as graft, 6.2 centimeter. So the length of the second toe was exactly 6 centimeter, and 2 centimeter graft was taken from the metacarpal. So we planned. So this is basically the procedure. All these diagrams are made to show the patients. So this is the procedure. Okay. So basically we had taken the second toe. So we can see the extensor tendon. So this is the second toe where we show the extensor tendon, flexor tendon, nerve. We got 4 nerves, 2 dorsal and 2 volar plantar nerves, and out of which artery and then the vein. So we got 2 veins. So I think this video shows the final. So this was the time of only the artery was connected at this time of removal. So you can see the artery connected. Following which we will keep this toe for a period of half an hour just for reperfusing and assure that it's viable again. So as discussed earlier, all this, the same thing will be dissected over the hand also. So we should find an extensor tendon, flexor tendon, artery, veins, and even the nerves. 4 nerves we have to identify, and we have to anastomose finally. This is the final outcome. And a small area measuring of 2 centimeter where skin graft was used for the raw area. And this is the dorsal, and this is the volar picture. So this is soon after the surgery. So you can see the viability of the toe bar finger. So this is the procedure. So we completed the procedure. Now it's almost 3 months. So this is the final outcome. You can see we have removed the final K-wire 3 months back. 2 weeks back, sorry, of the MCP joint. And this is the other view. So what we offer basically is so he had an exam 1 week back. So he started writing. So for the talk, I had asked him to write and send me a video. Yesterday night he had sent me this. So basically for this toe transfer has been indicated for basically for thumb. All these patients with a thumb deformity or loss of thumb in congenital cases or due to any traumatic cases, we can use for the thumb. So we use second toe bar first toe also depending upon the size. Now initially it was first toe, and now people prefer the second toe because the size is having a very good match. So currently for this case, it's not ideally indicated. Since the patient has requested, we have done toe transfers for this patient, sir. So second case, we'll have 2-3 cases. So this is a 60-year-old female who had a non-healing ulcer over the thumb. So this is the defect, and she has done dressing for a period of 3 months, and this was not healing at all. There was debridement done in 2 hospitals where wound was not healing, and there was pus pouring from the raw area. So, and she also has complaints, there is no sensation towards the thumb. And when she is holding any object, such as holding any cup of tea or whatever, she is not able to feel any sensation. So at this point of time, what we can offer is an island flap. So basically, if you see the first picture is the marking of the island flap, and the second picture is basically the flap along with the artery nerve, digital nerve has been taken. And this is the final outcome. So you can see the flap covering the defect completely. So before this, we had done 2 debridement and assured, and culture was taken and assured there is no infection. So this is the final outcome. Now currently she is able to move all the fingers and do all activities, and she is also having sensation. The only problem that patient is going to tell you is that if you are touching on my thumb, I am feeling over my middle finger. So that eventually she will get adjusted to it, but ultimately she has sensation towards his thumb. So the third case where a 16-year-old female presented to us with a swelling over the wrist, and X-ray shows there is some lytic lesion of the distal radius. And we had sent that for the open biopsy. This is following the biopsy, and she had a recurrence after 8 months. It was the biopsy report was giant cell tumor, and she required 4 cycles of radiation therapy for the same. And for the recurrence, again, we had removed the complete bone along with the soft tissue extension block. Excision of soft tissue and radius was done, along with the proximal row also was removed. And we had planned for a vascularized free fibula along with artery, vascular pedicle. So this is the defect following the removal of the tumor. And this is the vascularized fibula taken from the ipsilateral leg. The fibula along with the artery, you can see the clamps behind where the artery has been ligated and kept. So this is skin paddle. So this is following the surgery. And this is fixation. And soon after the fixation, the patient was good, and she was immobilized for a period of 6 weeks. And we started mobilizing after 6 weeks, and slowly she presented to us with a fracture over the proximal part. If you see the picture, proximally you can see the fracture as implant fracture has occurred, and we had done refixation with bone grafting for the same. Currently she is doing well. She also had deformity, like we also had removed one tendon over the thumb, and she had difficulty in extending the thumb. If you see the thumb has been flexed position in all these pictures, and later on we had done thumb extension, tendon transfer was done for the thumb extension for the same. Currently she is doing good, and this is the final outcome. to see the defect, and this is following the flap settling. So this is 1 year follow-up. So this boy is 11-year-old boy, Arabic patient, presented to us with congenital deformity of wrist. He is not able to extend the wrist at all. It's in wrist flexed position, and no activities. He is not able to perform any activities. Elbow movements are full, rotations are full, but wrist is in flexed position. So ultimately, he is not able to hold any objects in his hand. So basically, we had opened and done a simple flexor tendon fractional lengthening, following which he is able to do all activities. So this is a functional outcome. You can see he is able to flex and hold the objects and do all his routine activities. So this was done 2 years back. Currently, patient is good. So this is the final case of brachial plexus. So we all know brachial plexus is complete paralysis of upper limb. So basically, we hand surgeons say it's like a current circuit where you on a switch, the light on, fan gets on. So basically, brachial plexus is like a current circuit where it gets injured. The first picture shows where the brachial plexus is working. Second picture shows it's not working. So basically, we have 70 muscles towards the upper limb. And once the brachial plexus get injured, all the 70 muscles doesn't work, and eventually the limb becomes paralyzed. So this is the presentation of the patient where he is, the right side is working well, and left side he had brachial plexus injury. He is not able to abduct the shoulder or flex the elbow. He is able to do flexion of finger and extension of finger. So this is the video, you can see. He is able to do movements in his right upper limb, and left side he is not able to do any activities. So we basically had done a nerve transfer for this patient. We had taken spinal accessory nerve which supplies trapezius. So spinal accessory nerve has been taken and given to the musculocutaneous nerve for the musculocutaneous nerve. Sorry, spinal suprascapular nerve for the shoulder abduction, and other one over the elbow which you see here. We have taken median nerve fascicle and ulnar nerve fascicle and connected to the musculocutaneous nerve for biceps and brachialis. So this is 6 months follow-up. Sorry, it's rotated. He is having 40 degree of abduction, and elbow flexion is 110 degree. And this is 12 months follow-up. You can see his abduction is near normal, 110 degree, and flexion is complete. Currently, we are expecting shoulder movements to be improved till the period of 18 months. So, in case of brachial plexus, it present as two scenarios. One is global brachial plexus, and other one is partial brachial plexus. So, upper extended or partial brachial plexus, and global brachial plexus, it will be complete paralysis, and upper extended brachial plexus, the shoulder and elbow won't be working. All other functions will be there. For this patient, it was upper extended brachial plexus. So what we have basically done is we had taken functioning nerve and given to non-functioning nerve. So patient is able to do his activities such as shoulder and elbow movements. So this is the final case where the duplication of thumb dactyly. So it was a bilateral thumb deformity. So here the only challenge was one was cosmetic, and out of which two thumb, one was cosmetic and other one was functional. Basically, one thumb was working and other thumb was not working. So that is basically cosmetic. And other hand, one function has been divided into two thumbs. So basically, if you remove one thumb, the function, half the function will be lost. So one side, left side, we had removed the cosmetic part, we had removed the thumb and covered it. And opposite side, what we had done is we had removed the extra thumb, duplicated thumb, and thus removed the all the collateral ligaments, all the structures which support for this function, and then attached to the thumb. So this is the final outcome for the left side, where we had done reconstruction. So you can see all functional movements what is able to do. Thank you.
Thank you, Dr. Febin. That was a very interesting talk. And the videos as well as the outcome looks very impressive. I'm sure there will be some doubts from the surgery orthopedic colleagues. Before that, my original thing, like, you find a lot of patients with deformities like hallux valgus, swan neck deformities. Hand surgeon, what do you recommend for them? Do you recommend surgery or you advise some conservative measures?
Sir, swan neck deformity, all this deformity, initial phase we try with conservative such as splints, night splints and physiotherapy initial stage. We wait for at least 3 months, see whether patient the non-surgical treatment, therapy and splinting. If patient doesn't improve and he is not able, he is having any functional deficit that he is not able to do any activities, so we suggest him surgery such as tendon transfer or arthrotic bone procedures.
Thank you. Any other questions? Dr. Jalil?
Just a comment. Why did you choose that normal skin rather than the glabrous skin for the grafting?
Sir,
Because that later on that will look very odd.
Okay, sir.
Because of the pigmentation.
That scenario, I think long term, we never expected that we will require a grafting. And that point of time, we were trying for a closure. And then we thought, we didn't think as you said, we just took graft from the thigh and just we grafted it. So we can even try for the skin graft taken from the foot as well, but we are taken from the hand, sir. Thigh, sir.
Okay. And the second case, that Moberg
flap
was a choice.
Yeah.
So that didn't suit for that second case.
Sorry?
Second case for that thumb.
You
thumb
want me to
defect,
show, sir?
Thumb defect.
Yeah.
Was it possible to do a Moberg flap?
Moberg flap, sir, for that patient, there was no sensation, sir. There was no sensation towards the thumb. So if you do Moberg flap, there won't be sensation. Only thing is we can able to cover the defect, that's all. So she require a sensation. Her 2 complaints, one was non-healing and other one was no sensation towards the thumb. So which we have taken the digital nerve from the middle finger and kept it over here along with the artery. So that was the reason why we had done island flap, sir.
Okay, thank you.
Thanks.
Any other questions? Thank you, Dr. Fabin.
Thanks.
I request Dr. Jayachandran sir to hand over the memento to Dr. Fabin. Thank you. The next speaker is Dr. Binoy J. Paul, consultant rheumatologist, a very senior rheumatologist practicing in Kozhikode. His topic is investigations in rheumatological disorders. Welcome, sir. The stage is yours.
So we are moving on to another important topic. As you know, joint symptoms are common in our community, and whatever be the specialty, you are likely to encounter patients with joint symptoms. So when somebody comes with a rheumatological symptom, how to proceed? What are the common investigations to be done? And that is very important. And one thing we should remember is investigations. We should not be ruled by investigations. Investigations have got their own limitations. So we have to interpret them based on the clinical picture of the patient. So it is very important to know about this topic. And to talk on this, we have a very eminent speaker, Dr. Binoy J. Paul. Sir doesn't require any introduction to this audience. He is one of the national figures in the field of rheumatology. He was the Vice President, National Secretary of Indian Rheumatology Association. And Sir has been the pioneer of rheumatology in Kerala. In fact, he was the president of IMAAMS also, Kerala State Chapter, if I remember. In fact, we all joined AMS when he was the president. And Dr. Binoy Paul is currently the professor and head of the Division of Rheumatology in KMCT Medical College. He was the former professor of medicine in Calicut Medical College. He has authored 3 very interesting, very popular textbooks in rheumatology. They are very popular among the students. I welcome sir to address this.
Thank you, respected Chair Dr. Jayachandran, other senior colleagues and friends. At the outset, I thank the IMA Calicut for giving me this opportunity to discuss about the investigations in various rheumatic disorders. If you look at the investigations in rheumatology, you could see a very long list, starting from acute phase reactants like ESR, autoantibodies, bacteriological tests, blood counts, biochemical tests, electrophysiology, synovial fluid analysis, genetic linkage studies like HLA, histopathology, imaging, and the number of investigations are rising day by day. So we will start with the very basic things first. You know about acute phase reactants. It's a pathophysiological event in which there is a response of the body to inflammation. So in acute and chronic inflammatory process, there is elevation of the acute phase reactants. The commonest acute phase reactant we usually look is the ESR. Then CRP and ferritin also are other acute phase reactant. We do it in very selected cases. Acute phase reactants help you to differentiate between an inflammatory arthritis like rheumatoid to a non-inflammatory arthritis like osteoarthritis. And you also can assess the extent of inflammation depending on the rise in the ESR. If the disease is very active, the ESR will also be very high, and also useful to detect complications like infection in the scenario of lupus. So ESR gives a composite of various acute phase proteins like fibrinogen, globulins, etc. The fibrinogen and alpha and beta globulins are the major contributors of ESR. Immunoglobulins contribute to a lesser extent. It is influenced by age of the person, sex, hemoglobin level. The average ESR, the upper limit is age by 2 in a male and age plus 10 by 2 in a female. So a male person with an age of 40, the ESR upper limit will be around 20. For a female, 40 plus 10, 50 by 2, that is 25. So it varies with the age, sex, and hemoglobin level, and it rises slowly once there is inflammation sets in, and also slow to fall also. And one should always use fresh samples if you are estimating the ESR, but it is still a very cheap and manually doing investigation, very useful to differentiate between inflammatory and non-inflammatory arthritis. If you take C-reactive protein, the CRP, it is more specific and more sensitive than ESR, and it starts rising early within 6 to 10 hours after the onset of inflammation. Last only a few days after subsidence of inflammation, it comes down. It is automated and more expensive compared to ESR, but can be performed in the stored samples also. So how do ESR and CRP differs? Measuring CRP in the laboratory is a more direct measure of inflammatory process. On the other hand, ESR is a more of an indirect measure. So you can see at the onset of inflammation, the CRP rises fast and comes down fast. ESR rises slowly and coming down slowly. And this I have already told. There are various factors which changes the ESR but not CRP. When you see a person with a raised ESR and normal CRP, always think about conditions other than that produce high ESR, like anemia, hyperlipidemia, and hypergamma-globulinemia. Among the inflammatory disorders, only SLE, you get raised ESR and normal CRP. In an SLE patient, if you get a high CRP, you have to think about associated infection. Because even in active SLE, CRP will be normal. Now, ferritin, there is a moderate rise in all inflammatory disorders, but when you get very high ferritin, there are certain rare diseases like adult onset Still's disease, and as well as systemic onset JAA, macrophage activation syndrome, catastrophic antiphospholipid syndrome. These are certain scenarios where you get a ferritin at a very high level like 5,000 or 10,000 value. Now coming to the various immunological tests, we have an array of them starting from ASO titer, rheumatoid factor, ANA profile, dsDNA, antiphospholipid, ANCA, anti-myositis antibody panel. So there is a very big list of immunological tests. But the most common investigation done by a general practitioner is often ASO titer. Please remember that a positive ASO titer suggests only a recent streptococcal infection. It is not equivalent to rheumatic fever. Significantly high titer occurs within 3 to 4 weeks after streptococcal pharyngitis. And high titer may persist up to 6 months after a single infection. So a little arthralgia or arthritis with ASO titer, high ASO titer, is not equivalent to rheumatic fever. You have to look at the clinical scenario and diagnose the disease. Other investigation that is commonly done is rheumatoid factor, which is an anti-IgG immunoglobulin. And usually we measure the IgM class of rheumatoid factor. There are different tests, Roswaller, latex site test, and nephelometry is the most popular and more accurate method in the current life. Rheumatoid factor will be positive in around 65% of rheumatoid arthritis. That means around 30-35% of patients with active rheumatoid arthritis, rheumatoid factor will be negative. And if it is positive, it stays positive. And at least 2 positive tests at 3 months apart should be taken as positive in a setting of connective tissue disease. So rheumatoid factor can be positive in rheumatoid arthritis, but many other scenarios like infections, connective tissue diseases like SLE, Sjogren's, progressive systemic sclerosis, other autoimmune disorders like fibrosing alveolitis, sarcoidosis, chronic active hepatitis, and even in old age, people above the age of 65, around 4 to 5% can have positive rheumatoid factor. So a presence of rheumatoid factor doesn't mean that the person is having rheumatoid arthritis. So joint symptoms with positive rheumatoid factor is not equivalent to rheumatoid arthritis. Rheumatoid factor is not needed to make a diagnosis of rheumatoid arthritis. As I said, 1/3 of patients with active rheumatoid will have negative rheumatoid factor, and presence of rheumatoid factor does not mean rheumatoid arthritis, as there are so many other causes. Another common recently arrived test is the anti-CCP, antibodies to cyclic citrullinated peptide, which is having a high specificity for rheumatoid arthritis. So when you get a very high titer of anti-CCP, 95% of the cases it will be rheumatoid only. And the sensitivity is about 70%. That means 30% of people with rheumatoid arthritis can have negative anti-CCP. It present early in rheumatoid arthritis even before developing arthritis, and high titer correlate with erosive changes in the bone. So when there is a very high titer, there is a chance of developing erosions and deformities. And it is expensive compared to rheumatoid factor. Average cost will be around 1,000 rupees in most of the labs. And it can be positive in low titer in psoriasis, psoriatic arthritis, SLE, and even tuberculosis. But when you get very high titer of anti-CCP, the chance of rheumatoid arthritis is very, very high. Another commonly asked test is the anti-nuclear antibody, which is widely accepted but inadequately understood test. These are autoantibodies against the nuclear component of the cell, like a DNA or snRNP. But ANA detects antibodies against nuclear and cytoplasmic specificities. Even though we say anti-nuclear antibody, every time it need not be against the nuclear component. Rarely there can be cytoplasmic antibodies also are included in this group. So there are different types of anti-nuclear antibodies, like chromatin associated. The classical is double-stranded DNA, anti-centromere, Smith, ROLA. So many antibodies are occurring against nucleus, nucleolar component, as in the case of SCL70, ribosomal RNP, and sometimes against cytoplasmic specificities. Jo1 is a cytoplasmic antibody, but that is also included in the investigation panel along with ANA. So these are different antibodies against various components of cells. So it is anti-cellular antibodies, that is a better name. And these are positive in certain autoimmune disorders. Anti-nuclear antibody will be positive in 98% cases of SLE, but 4 to 8% of normal population can also have positive ANA, and positive ANA can occur in many conditions other than SLE. So it is an excellent test to rule out lupus. If you get repeatedly negative ANA, the chance of SLE is very low. But if it is positive, it can be SLE or so many other diseases. So it cannot be used to monitor the disease activity. If the level is high, you cannot say that it's a severe disease. So there are so many other causes other than SLE which can produce a positive ANA, like other connective tissue diseases like rheumatoid arthritis, progressive systemic sclerosis, polymyositis, mixed connective tissue disease, other autoimmune disorders like myasthenia gravis, autoimmune thyroiditis, acute leukemias, transiently in viral infections, chronic liver disease, and even in the old age. So a positive ANA is not equivalent to SLE. You have to identify the clinical context where this test is asked. There are different assay techniques. I'm not going to the details, ELISA, radioimmunoassay, and the immunofluorescence. The ANA immunofluorescence is considered as the gold standard method for making a diagnosis of positive ANA. So there are, depending on the immunofluorescence pattern, you can have some idea regarding the underlying anti-nuclear antibody that is causing this pattern. When you get a homogeneous pattern, you can think about dsDNA. You get a ring pattern also due to dsDNA, a nuclear pattern due to SCL70 and snRNP, a speckled pattern you can get in Smith and these type of antibodies. So ANA immunofluorescence is the gold standard test. So when you see that your patient is having a positive ANA, always do it in the immunofluorescence method. That is the best thing. And ask the lab to preserve the sample if it is positive, because you may have to do other antibody test if it is strongly positive. And you have to study the clinical presentation, staining pattern, and decide on the antibody subset and do an ANA profile where you can get the panel of anti-nuclear antibodies which are positive in different conditions. Due to the lack of time, I am not going to the details of this. For example, dsDNA is positive, you think about systemic lupus erythematosus. If you get a UNRNP positive, you think about mixed connective tissue disease. So you get important investigative evidence of that particular connective tissue disease. So this patient is having MCTD, the UNRNP is very strongly positive. This is the control. This is SLE Jogren overlap. You can see the different antibodies that are positive. So from the ANA profile, you get an idea regarding the pattern of antibody that is present in this patient. Antibodies specific for SLE are dsDNA and anti-Smith. Anti-PCNA is also can be positive in ANA. These are specific antibodies, but the prevalence of anti-Smith antibodies only 30 to 40% in Asian SLE, and anti-PCNA is also proliferating cell nuclear antigen. This is also highly specific for SLE, but positive in only around 3% of people. with active SLE. So while anti-dsDNA is more specific, more sensitive, and it will be positive in 65 to 70% of the cases and predict the severity of the disease, it can be used to monitor the disease activity. That is why we usually do only anti-dsDNA in when you have a suspicion of SLE. And there are different assay techniques, the immunofluorescence, the radioimmunoassay, the ELISA. Commonly available is ELISA, but the best one is the Cryptidia luciliae immunofluorescence test. This organism contains a kinetoplast that having double-stranded DNA and antibody against this. When it is treated, it will be stain positive. So that is why it is called Cryptidia luciliae immunofluorescence test, the ideal test for double-stranded DNA. Very rarely you may get a negative in SLE. I said 98% cases it will be positive, but 2% it can be negative if only anti-Rho positive, massive proteinuria, when you give high dose steroids or immunosuppressives, or in primary complement deficiency causing SLE, like C1q deficiency lupus. So these are some of the very rare situations where you get a negative ANA but the patient is having SLE. Another group of antibodies we usually do in selected cases are antiphospholipid antibodies, which are heterogeneous group of antibodies bind to negatively charged phospholipids. And when you suspect a patient is having recurrent venous or arterial occlusion, recurrent abortions, thrombocytopenia with thrombotic tendency, young stroke, that is the situation where you should think about antiphospholipid antibodies. And there are 3 antiphospholipid antibodies commonly done: anticardiolipin, lupus anticoagulant, and beta-2 glycoprotein 1 antibody. And I think I can quickly go through this. Anticardiolipin antibody, lupus anticoagulant, and beta-2 glycoprotein 1. This is the newer antibody, and this constitutes around 95% of the antiphospholipid antibodies, but less than 5% there can be other antibodies. So if the classical antibodies are negative, you can ask for a complete antiphospholipid panel if your clinical suspicion of antiphospholipid antiphospholipid syndrome is high. Then another antibody test is autoantibodies to cytoplasmic constituents of granulocyte. This is anti-ANCA. These are 2 types, C-ANCA and P-ANCA, which can be done with immunofluorescence as well as ELISA. C-ANCA is positive in Wegener's granulomatosis, while P-ANCA is positive in Church-Strauss syndrome, microscopic polyangiitis, crescentic glomerulonephritis, and also sometimes in Wegener's. Wegener's, both can be positive. In inflammatory myositis, we have an anti-myositis antibody panel, which is still complex and evolving. So I am not going to the details of this. There are different anti-myositis antibodies causing different types of autoimmune myositis, like polymyositis, dermatomyositis, inclusion body myositis, or even cancer-associated myositis. So in some of the myositis, when you have a suspicion of malignancy, these antibodies will be useful, anti-TIF1 and anti-NXP2. These, if they are positive, the chance of this myositis due to an underlying malignancy is very likely. Now we may have to do a bacteriological testing when you are a suspicion of infection. It's not moving. Okay. So you may have to do Mando test, earlobe smear, or other causes of infection which may present with polyarthritis. This patient came with polyarthritis. Mando was very strongly positive, suggesting a diagnosis of a tuberculous etiology. This patient came with a rash similar to SLE, but he has Hansen's disease. So sometimes infection may mimic connective tissue diseases unless you look carefully. hematological profile is very, very important because leukemia is an important cause of arthritis, especially in children. Hemophilia and sickle cell anemia are well known to present with arthritis. So beware a patient with consanguinity, family history, and recurrent rather than persistent symptoms. You have to think about these possibilities. Various biochemical tests are important. I am not going to the details. Biochemical monitoring and various electrophysiological tests to find out any involvement of the muscle or nerve. Various histopathological tests may be needed, like a lupus nephritis, where you may need a renal biopsy, a vasculitic neuropathy, you may have to do a sural nerve biopsy. And a variety of imaging modalities are also available, starting from plain X-rays, MRI, angiography, ultrasonography of the joint. Because of the lack of time, I am not going to the details. This itself is a big topic. And genetic linkage studies, usually we do mainly HLA-B27, which is present in 10% of general population, but positive in 95% of the Caucasians and 50% of the blacks with ankylosing spondylitis. So if you are made a diagnosis of ankylosing spondylitis with bamboo spine appearance and all, there is no need to do an HLA-B27. It is useful in a case of suspected spondyloarthritis. A person coming with anterior uveitis of the eye with back pain and normal MRI, an asymmetrical oligoarthritis or recurrent enthesitis in a female patient. These are the situations where you have to do an HLA-B27. A woman with inflammatory backache, but MRI is normal. So that is the situation where these investigations are useful. So very rarely we may do HLA-B51 in Behçet syndrome and B5801 in allopurinol hypersensitivity. These are rare situations where we are doing this HLA. Most of the time, the only investigation is HLA-B27. So it is not uncommon to see patient with a lot of symptoms, no signs, and normal investigation. They are coming with aches and pains all over. So we often diagnose them as fibromyalgia or depression. But don't forget the occult malignancies, endocrine problems like hypothyroidism or Cushing's, metabolic diseases like hemochromatosis or amyloid, all can present with aches and pains all over. So don't forget to investigate them in detail. So fibromyalgia is a very common symptom, or common disease with abrupt onset of arthralgia, intermittent symptoms of aches and pains, lack of functional loss. When you examine, the joints are normal and there are multiple tender points, and they have a lot of non-articular symptoms like insomnia, fatigue, irritable bowel syndrome, tension headache, etc. And very poor response to non-steroidal anti-inflammatory agents, and they may often respond to antidepressants like amitriptyline or fluoxetine. These are the patients who come to your consultation room with a very sad face and a thick file containing lot of investigations. 5 rheumatoid factor tests, 3 are positive, 2 are negative, 2 ANA, 1 is positive, 1 is borderline positive. So such people, you should be very careful. So what I want to impress upon you is that a rheumatological complaint is not equivalent to a rheumatological disease. A correct use of laboratory can lead you to a diagnosis. But don't forget that incorrect use of laboratory can mislead you to a diagnosis. ASO titer, rheumatoid factor, ANA, all can be red herrings or booby traps. So beware of Ulysses syndrome. It is the ill effect of diagnostic tests following a false positive screening test. You have unnecessarily done a ANA and it is found weakly positive. Now it is your responsibility to prove or disprove that this is false positive or not. Ulysses was the hero of Greek mythology. He was, after winning the Trojan War, later he was imprisoned in a distant island for more than 20 years. He was finally released and came back to his hometown. Nobody, including his wife, identified him, and he has to undergo a series of tests to prove that he is Ulysses. But his pet dog, which was very old at that time, was able to identify the master by smelling him or licking him. I think a good clinician should be like the dog of Ulysses rather than doing a battery of investigations in every patient. I think it is these are the rules of rheumatology, which is not given in any textbooks. So take it as my own rules. In spite of availability of all the investigations, please remember that rheumatology is still a clinical subject. You should recognize the pattern of joint involvement which give the important clues to the etiology and reconcile that the disease evolved in a temporal fashion. The patient may initially come to you with arthralgia, later with a rash. After a few months, he or she may come to you with nephritis, and only at that time the diagnosis of SLE is made. It is nobody's fault. And when you see a patient with aches and pains, think beyond connective tissue disease and rheumatic fever. It may be an infection, it may be a malignancy, a metabolic problem, or an endocrine disease. All can present with arthritis or arthralgia. And recall that many diagnoses are clinical. Whether it is psoriatic arthritis or Behcet syndrome, your laboratory has nothing much to help you. It is your clinical sense. You can make a diagnosis. And last but not the least, is that you should rule the laboratory, not become the slave of the laboratory. The diagnosis of arthritis is something like a jigsaw puzzle for a clinician. But if you take a detailed history, a complete physical examination, few important relevant investigations, and a reasonable period of follow-up, you can solve this puzzle very easily. There is no stronger test than a complete history and physical examination performed by an astute clinician. Pattern recognition is paramount in arthritis. Investigations are only supplementary. Thank you for the patient hearing.
Thank you, sir, for the very informative talk and also for the clinical pearls of wisdom. There will be some doubts or some comments. You have covered almost all the investigations, and one of the common things which we see is patients coming with a non-specific symptom, a uric acid done, which many time patients do on their own, uric acid. So when to treat this uric acid, if is it necessary, what can you enlighten on that?
Asymptomatic hyperuricemia doesn't require any treatment. If it is having associated disease like CKD, coronary artery disease, renal calculi, without joint pain, you may have to treat. Otherwise, asymptomatic hyperuricemia doesn't require any treatment. Only thing, lifestyle modification, finding out the underlying cause of this hyperuricemia may be useful.
Any other questions? If there are no more questions, we'll wind up the session. Thank you, sir.
Thank you, sir. I request the Jayachandran sir to hand over the memento. Thank you, sir. I request Pradeep sir to hand over the memento to the chairperson.
Now we'll have the prestigious one of the orations of IMA, Academy of Medical Specialties National Conference. And this oration is being delivered by none other than a past national president, a vibrant which IMA has witnessed during the last few years, Dr. V. Wankekar. And this is IMA Medical Education and Research Award oration. And he is a great surgeon, and he will be speaking on recent advances in anorectal surgery. And to chair the session, I would like to invite Dr. Pankaj Mudneja. He is a chairman of IMA National Headquarters, and Dr. K.V. Devadas. He is a past state president of Indian Medical Association, Kerala State Branch. I request the chairperson to occupy the dais and then take the proceedings.
Good morning, everybody. I invite Dr. Ravi Venkatkar speak on recent advances in anorectal surgery. You know, when we were residents and we were students, anorectal surgery was one thing which was given to the most. Now, the senior would really not go into it, fistulas and piles and all. It was left for the junior people to do it. But with widening of scope, and I'm very happy that our professor of surgery, Dr. Ravi Venkatkar, has chosen this topic, which has actually ignited a lot of interest with invention of lasers, and we are sure going to benefit from it. Dr. Ravi Venkatkar, please.
Thank you, Chairman, sir. Good morning, friends. The very learned and astute chairperson of this oration and a very dynamic and a thorough gentleman leader of Indian Medical Association and the national chairman of IMAAMS, my dear brother Pankaj Bhai, another very dear friend, a very hardcore, sincere worker, Dr. Devdas sir. As rightly said by our chairman sir, anorectal surgery was previously a very neglected topic. क्या हो गया? Most of you must have heard me talking on the various issues of the fraternity. And our own IME people were forgetting that I am also a professor of surgery and a practicing anorectal surgeon. So when Dr. Pradeep asked me on what topic would I like to talk, I said I would like to talk on some academic topic. So thank you and congratulations to all the organizers. Wonderful job. Sankar, the state president, Zulfi, state secretary and the president-elect Joseph, the national chairman Pankaj Bhai, his dynamic secretary Srirang, and all the entire leadership of IMA Kerala and the local branch of IMA Calicut. You have done a wonderful job. And I am very well aware of what all difficulties you faced. This got postponed and because of Nipah and so many other things. But still, you could do it wonderfully well. Thank you for all the hospitality and wonderful arrangements. And I am especially thankful to, again, the entire IMA, AMS and headquarter leadership for bestowing me with this honor of the Medical Education and Research Award. I would like to dedicate this award to entire IMA Kerala state branch. This is the model state branch in the entire country. Wherever, whenever I have a chance, I say all IMA leaders from all other states should go and visit IMA Kerala to see their functioning. And you have been guiding the headquarters. May it be late Velayadan Pillai sir, Marthan Pillai sir and now Asokan sir. So many stalwarts IMA Kerala has produced and wonderfully, it is really a model to be followed. Friends, just a small overview. I will not take much of your time. It is very common. Anorectal disorders affect nearly 20% of population. Especially renewed interest in it has come up because of changing in lifestyle. People are sitting much. People are eating less fibers. All these things have led to a rise in anorectal conditions. There are at least 50 common anorectal conditions. We can't go into the details of each and every one. Right from simple pruritus, to anal cancers. Today, I will be limiting my talk only to 4 commonly occurring conditions and what are the trends which are coming into this management. These are the common symptoms: PR pain, PR bleeding, something coming out of the anus. 3 main presenting complaints. And usually they are confused. All 3 can be present in any of the diseases. So your diagnosis also is very important. Per-rectal examination and proctoscopy, of course, are the basic gold standards. And one should not again forget the age-old adage that if you don't put a finger in the anus, you will put your foot in your mouth. Colonoscopy is required in limited conditions, especially when you are suspecting malignancy. Endoanal sonography, it has now become a mainstay. With newer machines, most of the conditions can be diagnosed by a very good endoanal sonography. And further, if we want to further evaluate, a MRI scan. All cases of fistula nowadays we submit to a MRI scan because that gives lots of information which is not available with a traditional fistulogram. Of course, then we do anal manometries in so many conditions, especially of fissure, fistulas, just to see it pre-operatively, post-operatively. Some of the fissures are low pressure fissures. Normally we associate fissure with spasm of sphincter leading to increased pressure. That is not the case. Biopsy, nerve conduction studies, difficography, especially in chronic constipation or incontinence. What is important to note that endoanal sonography and MRI have now really made our job much, much easier. What today I want to emphasize the main point in the problems of management of anorectal diseases, which is not the medical management issue. One, first, foremost is shame. Patient will not disclose even to his wife, or the son will not tell his parents that I am suffering since last 2-3 years, I get intermittent PR spotting, or if I eat spices. This factor of shame, not disclosing even to the closed ones, is the biggest hurdle, and then the patients come with severe anemia or unfortunately malignancy, then it is detected at much later stage. That is one big thing which one encounters in the management of anorectal diseases. The second is the misconceptions about management. That any anorectal surgery, 2 main misconceptions are there. One, you will have anal incontinence, and second, you will have a recurrence. 99.9% patients coming to my chamber for last 25 years ask only these 2 difficulties. Sir, I should not become incontinent, and whether it will come back or not. They are in a way right. Traditionally the Milligan-Morgan standard classical procedure for piles or the Lord's dilatation both led to certain amount of incontinence for few days at least. Because of this shame and misconception, alternative therapies are always tried. In no other field of medicine you will find quacks ruling the roost than in anorectal surgery or proctology, what we call as. You will get Bengali doctors, you will get Chansi doctors, you will get Rao doctors, n number of quacks in all small, big towns everywhere. And 50% of the patients have visited them, there has been some complication, and then they come to you. So these 4 things one has to always keep in your mind that yes, these are the issues. As a medical teacher, I need not re-emphasize this again when we talk of recent advances. There is a great deal of tendency that whatever new is good. If something new is there, it has to be good. That is not the case, especially in medicine, friends. That is why I am very fond of this, my quote of Sir Hutchison, which I always tell my PG students. That you should not have too much zeal for the new, neither you should have contempt for the old. You need to find a balance between all this. Bassinis repair for hernia was described in 1888. Still, that basic principle holds true today, even after 150 years. Whatever new may come, you need to complement each other. You just can't discard everything. Medical management, standard treatment, some metronidazole, some deworming, stool softeners, analgesics. What is important is lifestyle changes. Nowadays, young boys and girls sitting on computer for 10, 12 hours a day and wearing tight jeans and eating junk food, all of them are presenting either with a fissure or piles or pilonidal sinus. Let us talk about piles. Everybody knows what piles are. This is important for all of us also. We also sit a lot, especially the physicians of all specialities. We need to eat lot of fiber, drink lot of water, have good anal hygiene. If you are sitting for prolonged time, use a piles ring, please. Hardly cost 600 rupees on Amazon. Exercise regularly, of course, avoid caffeine, alcohol, all these things. Sitz bath works wonders. So as I said, lifestyle changes, medications we have discussed, hemorrhoidectomy. First, open hemorrhoidectomy, the classical Milligan-Morgan technique, described in St. Mark's Hospital, London, around 100 years back. It is now abandoned. Nobody does it. Neither you should do it, because it has lot of complications. Firstly, it leaves lot of raw area. Raw area, of course, causes chances more of infection. Pain is there. Reepithelialization takes few months, and anal stenosis chances are much, much higher because you have 3 big raw areas. So, classical open hemorrhoidectomy is out. For piles management, remember this one thing. You can do a closed hemorrhoidectomy, which is again a very good technique, especially for grade 3, grade 4. What do you mean by closed hemorrhoidectomy is a submucosal resection of the pile mass. And then we close back the mucosa so there is no raw area. Excellent results, rather the choice of treatment if you encounter grade 4, that is prolapsed thrombosed piles. Then last few years what gained traction was stapler hemorrhoidectomy, whereby a device, a large ring of entire anorectal mucosa is excised, and with the help of staplers, it is again sutured. Last 1 or 2 years, again because of complications, stapler hemorrhoidectomy has gone out of vogue. Especially anal stenosis is one major cause after stapler hemorrhoidectomy. What has gained traction today are the minimally invasive procedures. There are quite a few. The classical one, of course, was banding, which everyone is aware, rubber banding. Sclerotherapy. You inject sclerosants at the base of the pile mass so that the entire veins get obliterated. Infrared coagulation, IRC. Again, this banding, sclerotherapy, IRC are good. cryotherapy for grade 1 to grade 2 piles. Then nowadays what we are doing, three main things. One is radio frequency ablation. 2, laser hemorrhoidectomies. 3, Doppler guided hemorrhoidal artery ligation. All these three procedures are doing wonders in all types of piles. Many a times we have to combine therapies. If you have bigger pile mass, you do a DGHL or obliterate them by lasers. Concomitantly, you have a set of secondary small internal piles. You can do a sclerotherapy or apply a IRC. This is the stapler, first slide, where it goes inside, it cuts, and automatically once you close the stapler, it sutures also. Infrared coagulation. Infrared coagulation basically works only for early grade 1 piles. The last one, as our chairperson rightly said, that lasers in all fields of surgery have really revolutionized. Same year. This is the stapler inside, laser treatment, banding. Second most common thing is anal fissure. Very painful, extremely painful. Especially one symptom the patient will come, you can diagnose without doing anything, that post-defecation he has severe burning. I mean, for 10-12 hours the patient suffers from burning PR. And he is totally upset. No other diagnosis but fissure in ano. As I said, again fissures are becoming very common in younger age group. This is the flow diagram for treatment for anal fissures, medical management and surgical management. So many things have come up in the medical management: nitroglycerin, nifedipine, Botox. All these drugs tend to relax. The pain is due to the spasm of the internal sphincter. So all our efforts are going towards relaxing that sphincter and thereby causing relief of pain. Surgery. We all studied during our undergraduate days that Lord's dilatation or manual dilatation was the gold standard. Friend, just like Milligan-Morgan or open hemorrhoidectomy is out of question, today Lord's dilatation is totally out of question. It is criminal to subject now a patient to Lord's dilatation. It is cruelty against the patient. Now the gold standard is to do a lateral internal sphincterotomy. Either at 3 o'clock position or a 9 o'clock position, you go submucosally and cut around 30% of the internal sphincter. 92% times your fissure will heal automatically. You don't have to do anything. It is an office procedure, even can be done under sedation and local anesthesia. How you cut it, you can use a blade, you can use a scissor, you can use a RFA probe, you can use a laser probe, whatsoever it is. You just have to know the exact anatomy and do this procedure, and the patient is most happy. As I said, surgical anal dilatation or classically Lord's dilatation totally outdated. A lateral internal sphincterotomy is now the gold standard. In chronic fissures, we can do a anal advancement flaps, especially for low pressure fissures, which are very common after postpartum, after deliveries. There the pressure is not high. So if you do a sphincterotomy, again the patient will land up with incontinence. Fissurectomy, where you excise the entire chronic fissures, you can excise the entire ulcer. Certain novel therapies, as usual, you can sacral nerve stimulation. It has some papers are there where continuous sacral nerve stimulations for 6 weeks, either through the directly stimulating the sacral nerve roots or through the perineal nerve, then it is supposed to give relief. Certain centers are doing injection of the patient's own adipose tissue in the bed of fissure, and they are also claiming to have good results. Fissures, one small word of caution, HIV. How to treat, very common in HIV. It requires certain different skill set. Crohn's disease, fortunately not very common in our part of world, very common in the Western world, which again presents with multiple fissures. What we have is tuberculosis instead of Crohn's. So all these things and low pressure fissures, as I have already described. The important thing today is to try to understand fistula in NO disease. Highly complicated disease, and it is really a great challenge for any general surgeon, for any anorectal surgeon to treat fistulas. Because whatever you do, 10% of them will recur. Whatever techniques you use, multiple techniques have come. The very fact that when one treatment is not successful, you get multiple treatments. The very fact that there are multiple options available shows that no treatment is perfect. So one needs to understand this and keep this in mind. Also, one needs to keep in mind when we see all these techniques, many a times we have to combine various modalities for various treating a particular fistula in one single patient itself. See, surgery is the only option for fistula. There is no medical management, because we have to sever these connections from the exterior to the anal canal. They are as a result of inflammation, infection of the anal glands, leading to anal abscess, leading to fistulas. 40% of perineal abscesses will land up with anal fistulas. So surgery is the mainstay. Two main principles is, first is not to make the patient incontinent. Very, very, very important. Even at the cost of recurrence, one needs to operate in such a manner that the patient never becomes incontinent. This is the dreaded complication of any fistula surgery, patient landing as incontinent. It will make his life worse from what he has come to you. So first and foremost, you have to see to it that whatever you are doing, please, please don't make the patient incontinent. And second, deploy a technique where there will be minimum chances of recurrence. Fistulas are complicated. I have not gone into the types of fistulas, classification of fistulas. That would be too much. Simple fistulas are low fistulas basically, where they are usually up to the external sphincter or to the intersphincteric space. Very easy to treat. Either you can do a plain fistulotomy, open surgery, where you just lay open the tract. Some people do a marsupialization of that tract. Some surgeons excise the entire tract, do a saucerization and let it heal. Still a very good technique for low, simple, short fistulas. Problem comes with mid fistulas, high fistulas, complicated fistulas. Complicated thereby meaning having multiple tracts. High means above the internal sphincter. See, the continence depends not on the external sphincter, it depends entirely on the internal sphincter. You can cut open, throw away the external sphincter. What will be only the puckering of the anus will get lost. Otherwise, the main thing, 100% is our continence is controlled by the internal sphincter. So mid fistulas going through the internal sphincters or high fistulas going above the internal sphincters are very difficult to treat. So multiple techniques have come, multiple techniques. Laser fistulotomy, where you burn the entire tract, you core out the external opening, identify the internal opening, and then burn out the entire tract. Lift procedure along either independently or along with laser fistulotomies. Basically ligation of the intersphincteric tract. You again identify the internal sphincter, internal opening, and in between the external sphincter and internal sphincter you go and you ligate the tract so that nothing, it does not recur without damaging to the internal sphincter. Videoscopes have come into play where a very thin scope is introduced in the fistula, either then by radio frequency ablation or lasers. Under vision, you obliterate or cauterize that particular tract. Some centers are filling that fistulous tract with either fibrin glue or some autologous material trying to block it. There are also fistula clips, where you put a clip at the internal opening and at the external opening. And not to forget sitons. Sitons are some sort of thread put in the fistulous tract, and they allow it, the tract does not close, slowly and steadily. Everything is drained out and the tract heals. They can be loose sitons or they can be tight cutting sitons, where we tighten it every few days so that slowly, especially useful in very high complicated fistulas. Again, a very age-old techniques. Right from the biblical days, sitons were used, where you tighten it so it cuts 1 millimeter in 2-3 days. Simultaneously, it heals also. So, natural slow cutting with slow healing. That is the cutting sitons. So, sitons, so many times, as I said, so many other techniques, advancement flaps, I will not go into the details. Stem cell therapies have been tried, fistula clips, as I said. As I was telling you, fistulas, you need to combine various modalities as and when required in a particular patient. Say at 2 tracts are going upwards, maybe you can just do a RFA, you can do a lift procedure in between the sphincter if you can identify it. So many times because of recurrence, patient comes with a recurrence and then it is a big mess to identify the internal sphincter. This is the lift technique. This is the video assisted fistula treatment. These are the fibrin glues, either a commercial preparation or locally made preparations. These are the fistula plugs also. You get fistula plugs where you close them. These are fistula clips. Fistula management, again I will repeat, take home message is to avoid incontinence at any cost. And use of multiple techniques in a particular patient. Simple low fistula, do a standard fistulotomy. Why you want to subject him to a laser surgery? Lastly, very quickly, pyloneedle sinus, where a tuft of hair goes inside at the natal cleft and causes infection. Again, a very pyloneedle sinus disease is a very difficult thing to treat because it recurs. 40% recurrence, whatever you do. And as I said, prolonged sitting, then sliding. The hair in the natal cleft turn inside and cause infection, especially in warm climates like us. Why I said wearing thick jeans, it facilitates this particular pathology leading to pilonidal sinus. So, usually the patient presents with a pilonidal abscess where you need to do an incision and drainage, but remember, it has to be a paramedian incision. If you take an incision right in the midline, 100% there will be recurrence. Later on, he develops pilonidal sinus, again various modalities, same like fistula, you can do a laser closure, you can use a RFA. In complicated cases, or recurrent cases, various flaps have been described. I will not go into those details. Z-plasty flap, Lumberg flap, very commonly done. Again, a very difficult thing, but once you need to educate the patient for everyday hair removal from the natal cleft. Maybe you can even suggest to do a skin epilation so that the hair follicles are permanently damaged and there will be no growth of hair, especially in hairy males. And maintain a good hygiene even of the natal cleft. So today's take-home message, open pile surgery is outdated. So also surgical anal dilatation, that is Lord's dilatation. Fistula is a difficult disease. You need to combine therapies, but any surgery should not lead to incontinence. And cases of anorectal diseases are on the rise because of change in lifestyle. Thank you for patient listening. Thank you very much.
Thank you, Professor Dr. Ravi Venkatkar, for presenting an overview of the anorectal recent advances. I'll keep the house open for any questions to the... No questions to the oration. Sorry, apologies. It was very interesting.
You can ask the chairman. You have the right.
It was very interesting. And your take-home message is very well taken, that open surgery and incontinence need to be avoided. And thoroughly enjoyed every bit of it. Thank you very much.
Thank you, sir.
Thank you, Professor, for your excellent presentation, without shame. Thank you very much.
Thank you, sir.
Thank you, sir. I request the chairpersons to hand over the memento to kindly accept this memento, Dr. Devasya. Thank you. Now we move to the plenary session of Stroke Day. The chairpersons for this session is Dr. Velayudan, Senior Cardiologist, Kozhikode, and Dr. C.J. Joseph, Retired Senior Physician, Beach Hospital, Kozhikode. The first talk of this session is going to be thrombolysis by Dr. V.G. Pradeep Kumar.
Good morning. So we will go to the next session today. It is acute ischemic stroke management update. First, it is the thrombolysis. The talk is by V.G. Pradeep Kumar. Up to you.
The importance of this plenary session on stroke is that tomorrow is the World Stroke Day. All over the world, campaign to prevent stroke and for early identification as well as management of stroke is on the rise. And all of us are joining together. We have so many programs in Calicut, also various neurology organization and Indian Medical Association together. We are having a lot of programs. I'll be just touching upon the first part, IV thrombolysis of acute ischemic stroke management. We are not mentioning about the intracerebral hemorrhage. Following which Umar sir will mention about the mechanical thrombectomy part. We should have a rough idea about what is the gravity of stroke in the present day scenario. And the incidence and prevalence are in the various aspects of the globe. It's almost a tune of some 90 to 120 to the tune of 300 to 350 per 100,000 population. The crude prevalence in stroke in India in various states is given this marker. We can see this Kerala ranks one of the highest prevalence of stroke to the tune of more than 625 plus 100,000 population. That means for 1 lakh population, almost 625 people can develop stroke. Regarding the incidence, stroke incidence is, there are various registries have been published. Only few registries are there. The comprehensive registry ICMR is being now in the process of making it. Trivandrum stroke registry says about 135 plus per 100,000 population. And of ischemic is 75%, hemorrhagic stroke is 15%. Another registry is from Ludhiana, which is pioneered by Dr. Jairaj Pandyan and all from CMC Ludhiana. Incidence again 162 per 100,000 population. The Kolkata stroke registry says about 145 per 100,000 population. So almost the tune of say 125 to 135 per 100,000 population is the one. The importance of these incidence and prevalence is that what the economic burden on the country. It is for huge burden for the individuals, family, society and country at large. So the total cost in the first year, if it is a stroke, it's a mild stroke, that is MRS 0, to very severe stroke, the MRS 5, varies from $3,000 to about $15,000 per patient. That is the cost of this stroke. So what we can, how do we make the impact? By doing the proper management. The patient, initially it was aspirin for acute ischemic stroke. Now the scenario has changed. We have got IV thrombolysis. If the patient comes the window period of 4.5 hours. You should be very clear about that. Small vessel disease, medium vessel disease, within 4.5 hours IV thrombolysis. Large vessel disease, any window period. Any window period, initially it was up to 6 hours. Now even extended window up to 24 hours is based on the newer imaging technology. And then early supported discharge, that is another program or which is proposed. And comprehensive stroke care unit, where you should have a stroke physician, even an MD physician with trained in stroke. There's a stroke nurse who is aware of the complications. And then there's a physiotherapist, that will be comprehensive stroke unit. This is a very, very frightening data. Per minute, almost a tune of 1.9 million neurons die because of stroke. That is the most important thing. That is why we call time is brain. The pathophysiology, we have the ischemic stroke with a central core of infarct, where there is no blood supply, surrounded by a penumbra, so less blood supply, and an area of oligemia. The infarct, the cerebral blood flow will be 10 ml per 100 gram per minute. In the penumbra region, it will be about 20 ml, and the oligemic area will be little more. So we have, our agenda is to salvage the penumbra so that the penumbra will not go to the infarct. And this is the rate of growth of infarct. First you see at 6 hours infarct, the right mediastinal artery is like this. By 24 hours, the entire right mediastinal artery part is thrombosed. So that is the time, if we can recanalize, this is one patient, at 1 p.m. we have given the IV thrombolysis bolus, and you can see at 1:38 it started recanalizing, the left M1. So the publication of the IV thrombolysis with altiplies from 3 to 4.5 hours, that has changed the scenario, because initially it was up to 3 hours, then we had to 4.5 hours. The fear of symptomatic intracerebral is unnecessary. Only about 6% is having intracerebral hemorrhage. But the limitation is that utilization is only 5 to 10%. Patients should reach the stroke-ready hospital in that time. And larger NHS score, besides National Institute of Health and Stroke Scale score, more than 10. And large artery occlusion like medial artery occlusion, internal carotid, basilar occlusion, IV thrombolysis may not be effective. And if the clot length is more than 8 to 10 millimeter, it may not be effective. And again, large vessel occlusion, the rate of recolonization is less than 40%. So in such scenario, directly should go for mechanical thrombectomy. TPA dose of administration 0.9 milligram per kilogram body weight, 10% as intravenous bolus, followed by 90% infusion over 1 hour. And another molecule which is come into the market for the last 2 to 3 years, and now it is approved for use in India also, is tenecteplase, which is a little less costlier, and this dosage is 0.25 milligram per kilogram body weight. It is a single bolus compared to the other one, which is an initial bolus 10% followed by IV infusion. And the tenecteplase, there was trials on various doses, 0.2, 0.25, 0.4. And they found that more hemorrhage with 0.4. So the optimal dose, now it is recommended, is 0.25 milligram per kilogram body weight. And there is an aspect score, is a scoring system in the imaging where there are 10 points are identified, 10 areas are identified, and if those areas are affected, accordingly the score becomes less. So the score is less, the severity of stroke is high. It's Alberta stroke program. And again, CT angiogram will show clot burden score, the length of the, depending on the length of the clot also, there will be, outcome will be predicted. If the length is small, better outcome. And measurement of the collaterals by modified TAN system, that is also in the less than 1/3 of the 50% of the MCA, more than 50% of MCA. Collaterals are richly present, outcome is better. And this is another collateral scoring system, ITAP system, again that will be predicting the outcome. Imagine protocol if a patient coming with acute ischemic stroke, CT followed by CT angiogram and CT perfusion. That is a protocol. CT will give you the exclude hemorrhage. CT angiogram will tell you whether it's a large vessel occlusion or not. CT perfusion will give you the central core, how much is central core followed by the penumbra. And in certain cases, MRI will be useful to identify early posterior circulation stroke. You do not have to check serum creatinine before IV thrombolysis because CT angiogram, you directly take it unless the patient is having established chronic kidney disease. And again, aspect score I told, if the good scan is aspect score is very high, fair scan is 5 to 7, poor scan is score is low, with more and more areas are affected. So we can see that if a patient coming within the first 4.5 hours, if it's small and medium vessel occlusion, IV thrombolysis, and blood sugar should not be less than 50 and should not be more than 400, and blood pressure should be maintained to 180/100 to prevent further hemorrhage. Intracerebral hemorrhage after IV thrombolysis is approximately 6.4%. Anticoagulation, if the patient is on anticoagulation, what will you do? Conventional anticoagulation like vitamin K antagonists like warfarin and acetylene, you have to check PTINR. If the international normalized ratio is less than 1.7, you can take up thrombolysis. If it is more than 1.7, should not take up IV thrombolysis. If the patient is on newer oral anticoagulant, you cannot thrombolyze this patient unless you have a blood level estimation. So that is one of the limitations. If the patient has skipped treatment for 48 hours, you can take up this for IV thrombolysis. And we don't have the blood level estimation facility of the newer anticoagulant in our country. Minor strokes, low NHS does not mean low NHS. Because score is previously if the NHS less than 5, you need not thrombolysis. But if the patient has isolated lower limb weakness, like unable to walk, loss of speech or vision, these 3 conditions, even if the score is less, you can thrombolyze. Minor stroke, that is what I just mentioned. Intracerebral hemorrhage, if sometimes you do MRI, so microbleeds. If the microbleed is less than 10, you can thrombolyze, don't have to hesitate. And regarding the renal function I already mentioned, comparison between tenecteplase and alteplase, both are equally effective. And now the MR-guided thrombolysis has been initiated for up to 24 hours, trials are going on. And the intervention part, Umar sir will tell, endovascular treatment has come up, the large vessel occlusion which has saved many, many lives, and the number needed to treat is only 2.6. So how can we improve? System of care, first medical contact to the ED arrival, immediately somebody is being referred, they can inform the stroke-ready hospital, and we will immediately pay on arriving patient, imaging plus intravenous TPA or bolus dose. Then if the patient is mechanical thrombectomy, will go to cath lab straight away from the CT scan, and the reperfusion reperfusion procedure. So only the number needed to treat after endovascular treatment or mechanical thrombectomy is only 2.6 compared to 7 in IV thrombolysis. These are certain cases which I think Mercer will be mentioning about. So the infarct growth rate is very highly variable. Rapid growth is 50 to 100 ml per hour. Sometimes it can happen. Intermediate growth 3 to 10 ml per hour, and slow growth is 10 to 15 ml. The factors influencing are: one is blood sugar, and number 2 is poor control of cholesterol. Thrombectomy is being undertaken for various time interval, up to 24 hours to be tried. So to conclude, patient within 4.5 hours of acute ischemic stroke should receive intravenous RTPA if no contraindication. And those within 3 hours can be given to inactive place or active place, anything of sort. Patients with the large vessel occlusion within 24 hours of onset should have a mechanical thrombectomy done after appropriate investigations like CT perfusion or MR diffusion flare mismatch. Non-invasive vascular imaging should be done along with CT, that is CT angiogram and CT perfusion. Stroke systems of care should be in place to get the best outcome for patient. If an acute stroke patient comes to a hospital, if you don't have the facility to treat, immediately refer to a stroke-ready hospital. Don't give antiplatelet without doing CT scan. Patients on vitamin K antagonists, INR should be less than 1.7. Patient on directly acting or newer oral anticoagulant should be selected based on the drug level, which is not available in our country. So such patients, if they have skipped treatment for 48 hours, you can take, otherwise don't take. And adedusizumab has come up for antidote of this oral anticoagulant. So thank you for the patient listening, and I request all of you to take part in various stroke day program tomorrow, 29th of October, because it's one of the very, very devastating disease. Unlike cardiology, I'm not negative. If you put in a stent, nobody will know that you are having a coronary artery disease. But stroke symbol, if it's acute infarct, can disable you for life. So every 4 seconds, every second 4 people are having stroke all around the world. So I thank you for your patient listening and request all of you to join this stroke day program. Together we can overcome the stroke. That is a slogan for the tomorrow stroke day. And now Umar sir will be doing mechanical thrombectomy. He has experience of more than 12 years now in probably one of the first person to start interventional neurology in our Malabar region. Thank you. Thank you so much.
Okay, next speaker is Dr. Umar, consultant neurologist, BMH.
A very warm good morning to one and all. And first of all, I would like to thank the IMA organizers and Dr. Vijay Pradeep and all other colleagues. And I think as Pradeep told, stroke is one of the most important. The second devastating disease after CAD. And in Asia, the incidence is increasing. And I think we should, it's a high time that we should give sufficient importance to stroke prevention and stroke care. So, as Pradeep was telling, this is the FAST, F-A-S-T, face, arms, speech, and time. If there is one, there is a sudden facial droop, limb weakness, speech disturbance, you shouldn't wait and waste the time. No, without much ado, let me talk a few words on mechanical thrombectomy. So the gold standard is IV thrombolysis within 4.5 hours. And if there is a large vessel occlusion like the carotid artery, the medial cerebral artery, vertebral artery, or basal artery, then we shouldn't wait. that you should go. Maybe we can wait for a few minutes and see whether a patient improves. Don't wait. If the large vessel occlusion, because the chance of recanalization is in the tune of 8 to 30% only. For some people, it's 8%, especially in basilar artery occlusion or carotid artery. In case of MCA, these 30% can get opened up, but 70% still there's a large clot burden. Patient may not improve. So we have to actively suck out the clot or bring out the clot by a retrievable stent. So we can do either a suction thrombectomy or a stent retriever, or we can have a combined procedure, or even make a angioplasty, stenting. Everything can be done in one go. This, as I mentioned, it can either be a direct aspiration of the clot, because you keep the microcatheter just proximal to the clot. Either you can aspirate it, or you can put a retrievable stent and remove the stent after deploying for a few minutes, like 3 minutes or 5 minutes, and bring out the clot to the outside. But at the same time, you aspirate from another port. Or you can have a combined suction thrombectomy as well as a retrievable stent. This is as the number needed to treat is 160 in the case of statin, and in the cardiac intervention it is around 42 per person. As you go down, you can see that in the Aurora trial, the Rivascat and Escape, Extend-I, and all the stroke trial, the number is quite few. It's like 2, 3, 4, like that. So that's the importance of treating a stroke patient, because you can save lives. They can come back to their normal quality life. Many trials until 2014. People were in doubt whether we should go about, whether we should treat, because until 1995, the treatment would be aspirin and statin, that's and anti-edema measures and all. Then 1999, they started intra-arterial thrombolysis with the urokinase. Then 2000, from 1995, the IV, the Actylase came. Then 2008, then the ECAS-3 showed that it's effective up to 4.5 hours. The intra-arterial came. Then there is a time of doubt whether we should go about, whether the intra-arterial is good, whether it's mechanical thrombectomy is good. So many trials showed that it's not effective. Until 2014, people thought that it gives more harm than benefit. Then after 2015, there's a tens of trials. Everyone was positive. Some of them are the Diffuse 3 and Dawn trial. And the recent one, the latest one, that is, I think this April 6, 2023, is a SELECT-2 trial. We show that even a large core, like if as Pradeep was mentioning, there's an aspect. Aspect means the total volume of the brain where it's ischemic or infarcted or getting ischemia. So if there is a large volume, it's already infarcted, why would you remove the clot? There's no point. But even those cases, some of them might improve. That is important. Even a large core patient can still improve. That is the end result of the SELECT-2 trial. Now, this case, I think this done 2 weeks ago. This patient is a 69-year-old male with hypertension, and he had a CABG done 2 years earlier. He developed a sudden onset of weakness of left side, left upper and lower limb, and difficulty in speaking at 5 p.m. in the evening. So I had to go to UK, so I had to rush to the cath lab because my flight would be delayed. And his NIH score was 14. His BP was like this. He had hemiplegia, and you can see that the CT. This is what Dr. Priti was telling, the aspect score. Do you have a pointer, please? Pointer on. Pointer on. Okay, sorry. All right. Here you can see that this area is hypodense compared to the opposite side. Similarly, this also, because it's the insular region and part of the basal ganglia, and there is an effacement of sulci in the temporal lobe. So there is an early infarct. Maybe the aspect score will be around 5, maybe 5 to 6. And this is the CT angiogram. We showed that there's a cutoff of the right MC, the right M1 cutoff. And this is the CT angio in the other stages. You can see that there's a collateral score is around 350 plus. That means he can still improve. And the CT angio showed there's a cutoff of the right middle cerebral artery just after the origin. The SA is normal. And this is the CT perfusion. This is how we do, just because if the time window is beyond 4.5 hours, or if you feel that the collaterals are bad, we go ahead with this is a MTT, mean transit time, and the Tmax. We show there is a clear prolongation of the Tmax as well as the mean transit time on the right side in the scheme in the occluded area. And this is cerebral blood flow is diminished here. This is cerebral blood volume, which is also mildly diminished in the frontal, in the insula, and part of the basal ganglia, and part of the temporal lobe. That means this area must have been infarcted. But the rest of the brain is intact. That means if you still go ahead with remove the clot, and this is patient was taken to the cath lab, you can see there's a pile of collaterals is starting with the anterior cerebral artery, which is filling almost up to the M3. And this is the occluded area. This is injection from the left side. This is the lateral view. You can see that from this area onwards, there is no flow. There is no flow at all to the right hemisphere. And this is some flow through the anterior falx artery to the anterior cerebral artery. This is the posterior communicator artery. This is the anterior coronal artery. We are trying to supply some blood to the posterior part of the brain. This is the angio. We can see that there is no flow beyond this level. This is not perfused at all. This is the lateral view. You can see there is no flow. This is the APV. This is lateral view. And just one pass. Try to put the stent and mechanical, the suction thrombectomy at the proximal part here. And with 35 minutes, it was opened up, because I had to rush to the airport also. With the 35 minutes, it was opened up. And this is it. Sometimes it takes 3-4 times, to try to remove the clot partly, again trying and all. So fortunately for the patient, he improved very well. And this is him. Next day within 12. That is the weak side. All right. So this again, he has improved very well, except maybe mild facial. That is after 24 hours. I think in a few days or weeks' time, he would be back to NH. It was 16, it will be 0 or maximum 1. That means back to life. This case, actually, I want to present this case. I think I had presented this in many forums, but the importance is this was done before the various trials that it is effective. Because I had a call that patient has come with a coma. She was intubated and ventilated. She has a bilateral hemiplegia, very, very large stroke. So then I had whether to do something or whether to leave her like that. If she was left like that, she should be dead. So there is no evidence that it was effective. Now we know that up to 24 hours. I had done up to 31 hours also with a very good result. So I talked to the relatives. Then they told that the place this was the patient. He was in coma. E1, M1, VT, something like that. This is the dense basilar artery sign, because it shows that. Pradeep, am I exceeding time? Please. You can say dense basilar artery sign. That means there is a basilar artery is occluded. She was taken to the mechanical thrombectomy 7th hours, because at that time only 4.5 hours, the 6 hours, maximum 6 hours was the time. This you can see that the CT angio shows there is no flow beyond the distal basilar artery. This is the angiogram. You can see there is a saddle thrombus, and this whole part of the brain is there is a block. The PC is blocked. The distal basilar artery is blocked. You can see there is a saddle thrombus here. And the same thing was done with the catheter was placed, and at that time I used only this Solter stent because the penumbra was not available at that time. With a single pass, you can see there is a clot which is extracted from that region of the distal basilar artery, and you can see that this is fully flow has re-established as a TC3 recanalization, and showed a mild infarct only. This is how they usually these present with the acute onset of vertigo followed by altered sensory and coma. Once you find this sort of symptom, never diagnose anything else, because sometimes they may can have a tonic fit or a sudden vertigo and fall and LOC, loss of consciousness. This the patient after a month normal, no deficit at all. So these are the importance of treating cases. We had done hundreds of cases of mechanical thrombectomy with a very, very good result. This case was done 3 days ago, I think. This patient is Dr. Pradeep's patient only. 57-year-old female, after a viral infection, she developed a recurrent left-sided weakness, and she also had a hemorrhagic phalanx on the right eye, for the past 2 weeks. On examination, she was fully normal. There is no deficit at all, and she had hypertension, dysarthria, and all. This is the MR. MR showed there is a cortical watershed infarct in the right frontoparietal region, and you can see that there is a gross critical stenosis of the. This is the left common carotid artery, left internal carotid. This is the right internal carotid artery. There is a calcified plaque at the origin of the right internal cerebral artery. You can see that the left eye is supplying the right side. But the right side also there, but there is slow circulation time. There is a prolonged circulation time, indicates there is a hypovolemia on the right side. This is the CT. The angio show there is a critical stenosis there. And this is the plastic, there is a pre-dilatation, then a stent was placed, and this is stent, and afterwards you can see that the flow has re-established. There is no stenosis at all. And this is patient is back to life, back to normal, and hopefully she won't have any more further TIAs. This is the last case. This case had this patient had acute onset of hemiplegia and aphasia. He came within an hour. CT was normal. Angio showed dissection of the left ICA. This is the opposite side, the other side. See, there is called flame-shaped occlusion, flame-shaped acute thrombotic dissection of the left side, left internal carotid artery. So, because the treatment of ICA is rather very difficult, sometimes it won't get opened up, or the effect may not be there, then I thought that we'll just give it a try, because he was young, he was a doctor, then I thought that we'll just give it a trial. So patient underwent suction thrombotic. These are the suction catheter there. You can see there is a suction is going on. And after some time, it started opening up a bit. Then the flow is slightly coming, but still there is occlusion at the supraclinoid ICA, internal carotid artery. This is the intracranial circulation. It is poor, very much low. Then I tried angioplasty, distal to proximal with some flow. This is the balloon angioplasty being done, 3-4 times done. Finally, I thought there could be a large area of gap because of the dissection of the vessel. So a stent was put, and finally you can see the vessel is remodeled, or it was made or something. And finally the flow has re-established. And during the procedure, you can see that see, he improved in the cath lab itself. He tried to move, and after a few days, he had hemiplegia, total weakness there. This is post-procedure within a few days. And that carotid dissection can present with headache, eye pain, Horner syndrome, cerebral retinal ischemia. MRA shows crescent sign. DSA can show a string sign. The treatment would be endovascular therapy, angioplasty, and stenting. Thank you. Thank you very much.
Okay, thank you, Umar, for the first presentation. Well, how will you decide whether the treatment is angioplasty or thrombectomy? Which type of
Usually, we don't do angioplasty, but if there is a tandem occlusion, like because we had a couple of cases where there's a critical stenosis of the proximal ICA. The ICA is stenosed, and one clot has there, one embolized to the middle cerebral artery. At that time, what we do is, suppose if the patient already thrombolized, then the chance of, because giving double antiplatelets would be risky. So we just go ahead with the mechanical thrombectomy alone. We go to the MCA, middle cerebral artery, and suck out the clot. And either we do angioplasty and stenting at the same time, because there is a risk of bleed, because there is a 4 to 6% risk of bleed in case of post-thrombolysis. Because if there is a bleed, then we can't go ahead with the double antiplatelets. But usually what we do is we do a mechanical thrombectomy, come out, and after a few days, if a repeat scan showed there is no bleed, then we go ahead with the angioplasty. Rarely we do both at the same time. Because it's not a must that we do a angioplasty at the same time, because we can have always a window or a few days.
Thank you. Now it is open for the public. Arule. Deep. Dr. Pradeep ji, I have a doubt. Why did you get any information regarding the high incidence of CVI in Kerala?
Partly maybe due to the lifestyle, because of the high intake of oily food, fry items, non-vegetarian. So many issues, rice eaters. Now that people are advocating to use more of millets rather than rice and wheat. So I think partly because of lack of exercise and our lifestyle habits. And incidence of diabetes and hypertension are also more in our society. By 2040, 1 in 2 in Kerala will have diabetes. That is what the post projection.
So mainly lifestyle modification by Keralites will reduce the CV.
Yeah. Prevention is, ICMR is stressing on prevention, and then entire the secondary prevention, prevention of treatment of hypertension, treatment of diabetes, the lifestyle disease committee have formed by Government of India and ICMR, and now it is a very huge campaign going on all over the world. And IMA is one of the important platform. In national level also, IMA has got a hypertension prevention committee as well as hypertension complication committee, lifestyle disease prevention committee.
Your experience with the 1080 place, is there any special?
Actually, both are equally effective. Altiplase is 10 milligram bolus followed by 90% infusion. The other one you can give single bolus. Tenactiplase you can give single
Cheaper.
bolus.
1080 place is cheaper.
Cheaper. That is little more, less costly than the Altiplase.
Experience is it good compared
both
to?
are equally effective, sir. Both are equally effective. Especially when the patient is being taken up for procedure cath lab, we can give a single bolus shot, then we can take up surgery. If there is no carotid, significant carotid, long-standing occlusion.
To our floor. Some doubts from the floor? So if no doubts, we will close this session. Thank you.
Thank you very much, sir. I request the chairpersons, Dr. Veladhan sir and Dr. Joseph sir, to hand over the memento to the first speaker, Dr. V.G. Pradeep Kumar. Thank you. I request the chairpersons to hand over the memento to Dr. Umar. I call upon Dr. K.V. Raju sir to hand over the mementos to the chairpersons, Dr. Veladhan and Dr. Joseph. Thank you. We move to the next session. We'll resume after a 5-minute tea break. Thank you. We'll move to the next session. I first call upon Dr. P.K. Shekharan, retired professor and head of Department of Obstetrics and Gynecology, Calicut Medical College, currently working in PVS Hospital, Kozhikode, to be the chairperson for this session. Welcome, sir. Dr. Shaheen, consultant fetal medicine, will be the next speaker. Sir, please take over.
Thank you, Raju. Can you please introduce the speaker?
Okay. Dr. Shaheen is a consultant in fetal medicine. She works at the N-Care IVF Kannur and Dreamflower IVF, Kozhikode. Welcome, madam.
Okay, she is going to speak to us on
the topic is fetal medicine, current trends and figure
fetal medicine
perspective.
is a branch of separate branch as such, where the fetal medicine specialists are going to help the gynecology or obstetricians to pick up the abnormalities at the appropriate time and intervene in between to save the baby as well as the mother. Now, the advancement made is tremendous nowadays. By the end of first trimester itself, many of the problems that the baby or the mother going to develop can be predicted and picked up and corrected. Most of the structural anomalies are also able to be picked up so that you can make a decision. Many diseases like even preeclampsia can be predicted by the first trimester fetal medicine studies, and many things are coming up. So let us first listen to Doctor to what she is to share with us, and then we may have some discussion thereafter. Over to you, Doctor.
Thank you, sir. Good morning, dear seniors, and I'll be speaking today on current status and future directions of fetal medicine. Maternal fetal medicine, which is also known as perinatology, is a subspecialty of obstetrics, which focuses mainly on managing the health concerns of the mother and unborn fetus during pregnancy and shortly after delivery. This subspecialty has gained a lot of significance these days because of extensive research being carried in the field of fetal gene therapy and stem cell therapy. Dating back to his history, this subspecialty came into picture in 1950s, 1960s, where the procedures like amniocentesis and fetal blood sampling during labor helped obstetricians in early interventions. These early interventions prevented many perinatal mortality. Later in 1963, Albert William Lilly developed a course of intrauterine transfusions for Rh incompatibility, which is regarded as first fetal treatment. Later on, globally, many organizations came into picture for this subspecialty, and hence World Association of Perinatal Medicine was founded in 1991. Here's Mr. Professor Kypros Nicolaides, who is a professor of fetal medicine at King's College Hospital, London. He is pioneer and aptly called as father of fetal medicine, who has made significant contributions for this subspecialty. He has developed many methods of screening, like screening for preeclampsia, preterm labor, chromosomal abnormalities, and spinal defects. A new model of pregnancy care which is being proposed these days is turning the pyramid of prenatal care. That is, we do assess the risk factors that can have adverse effect on both mother and fetus in early first trimester, and depending upon this risk assessment, a customized care can be provided for that particular pregnancy so that the adverse effects to both mother and fetus can be prevented. Fetal medicine is not confined only to obstetric scans. It also includes aneuploidy screening, prenatal invasive testing, fetal therapy, and genetic counseling. Obstetric scans, which are also known as prenatal ultrasound. Here we use imaging technique to assess the health of the fetus in utero. These scans not only confirm us about pregnancy, but also give us an idea about location, gestational age, number of the expected babies. We do get a chance to screen the baby's health and as well as to look at the baby's risk for having any genetic disorder. Obstetric ultrasonography, most of the times it's two-dimensional ultrasonography, but use of 3D and 4D techniques do complement the routine 2D ultrasonography. The most common scans which are done in a pregnancy would be dating scan in very early pregnancy, nuchal translucency scan, next is anomaly scan and growth scan in third trimester. Fetal echocardiogram and neurosonogram are done in few indicated cases. Few fetuses require little more extra care, and hence fetal surveillance is important in some high-risk pregnancies like multifetal pregnancy, women with bad obstetric history, recurrent pregnancy loss, and RH-sensitized pregnancies. Prenatal aneuploidy screening is routinely done by biochemical screening or the use of cell-free fetal DNA. We do have fetal procedures like amniocentesis, chorionic villus sampling, chordocentesis to confirm the high-risk patients which we get from screening, which comes as high risk in screening. And in some pregnancies, we do recommend genetic counseling. So these are the 4 basic scans which a pregnant woman should be having. Dating scan in early pregnancy around 7 to 10 weeks. NT scan between 11 to 13 plus 6 weeks. Anomaly scan routinely done between 19 to 22 weeks. And fetal surveillance, which is growth and well-being scan in third trimester. Coming to dating scan, which is performed very early in pregnancy, this scan not only gives us the confirmation about the viability of the pregnancy, but also helps us date the pregnancy. In this scan, we get to know the location, whether it's an intrauterine pregnancy or extrauterine pregnancy, and hence extrauterine pregnancies can be taken care and dealt adequately. We also get to know whether it's a singleton pregnancy or multiple pregnancy, and we get an opportunity to assess the uterine wall and the adnexa and the masses which can have negative impact on the pregnancy. Coming to NT scan, which is routinely done between 11 to 13 plus 6 weeks of pregnancy. Nuchal translucency is nothing but collection of fluid behind the fetal neck. And increased nuchal translucency is seen in fetuses which may have chromosomal abnormalities, cardiac defects, or genetic syndrome. Screening by this one parameter, we can detect up to 80% of fetuses with trisomy 21. We have FMF and ISOC guidelines for performance of the scan. As we know, these days, this NT scan is not confined only for the measurement of nuchal translucency. We take it as an early anomaly scan in which a detailed anatomical survey of the fetus is being done and any lethal or life-limiting disorders can be picked up, and hence termination of pregnancy can be offered in such cases. Coming to anomaly scan, which is routinely done between 19 to 22 weeks of pregnancy. This is also known as TIFA scan or level 2 scan. Here we not only look at the detailed anatomical survey of the fetus, but we also study the position of placenta, umbilical cord, and amniotic fluid. We have ISOC guidelines for the performance of this scan. Coming to fetal echo, which is a detailed evaluation of the fetal heart and is generally performed between 20 to 22 weeks of pregnancy. It helps us to detect fetal heart abnormalities before birth and hence permits intervention during pregnancy, before and immediately after birth. By doing so, we improve the survival rate of the fetuses born with cardiac defects. We have ISOC guidelines for performance of the fetal echocardiography, and the most common indications for fetal echo would be women with pregestational diabetes, regardless of whatever be the HbA1c level, past history or family history of congenital heart disease, or any suspected cardiac anomaly during routine scan, or whenever we find any irregular rhythm in the fetal heart rate. Coming to fetal neurosonogram, which is again a detailed evaluation of the fetal brain, which is done during pregnancy after 20 weeks of gestation. It helps to detect the abnormalities of brain before birth, permitting interventions before and immediately after birth, and we can actually plan the time and place of delivery of such fetuses, hence improving the survival in these babies born with brain defects. The common indications would be past or family history of any inheritable spinal or CNS abnormalities, fetus with congenital heart diseases, suspected congenital intrauterine infection, or exposure to teratogens. Fetal surveillance scans or growth scans, which are generally done in third trimester. Here we evaluate the fetal biometry. That is, we take measurements, calculate the estimated fetal weight. We also study the amniotic fluid and the Doppler of the baby. These scans help us to ensure the baby's growth and well-being is normal. Routinely, growth scans are recommended every 6 weeks, but in some cases, like twins, like dichorionic diamniotic twins, we recommend scans every 4 weeks. Monochorionic pregnancies require a little more extra care, maybe every 2 to 3 weeks, depending upon the underlying fetal condition or complications. In these scans, we look for the size and growth of the fetus. Size is nothing but a biometric evaluation of the fetus in which we calculate the estimated fetal weight by measuring biparietal diameter, head circumference, abdominal circumference, and the femur length. Whereas growth of the fetus is a dynamic process and it requires multiple observation and growth charts are being plotted. Use of multivessel Doppler like uterine artery, umbilical artery, middle cerebral artery Doppler studies help us to evaluate the blood supply to the baby. These not only ensure the normal blood supply to the baby but also helps us in staging and planning delivery in cases of fetus which are affected with fetal growth restriction. We always look into the placenta, umbilical cord and liquor around the baby. By doing these many scans, we just really want to improve the outcomes. Outcome has different definitions. Obstetricians, they really don't want to have any hypoxic or acidemic baby, and there's a big no for stillbirth. But when we ask neonatologists, for them outcome is they do not want prematurity, they do not want morbidity, and definitely no neonatal deaths. But for parents, it's a healthy child. We as fetal medicine specialists are trying our best to improve the outcomes in the pregnancy. Routinely 2D scans would be sufficient, but use of 3D and 4D technology will be very complementing to our routine 2D scans. These scans and these images, clips, which ensure the babies are in the normal condition, but also gives us a depth of any abnormality when, if found, and it becomes very easy to explain the prospective parents about the fetal condition. Coming to prenatal aneuploidy screening, these tests were devised to increase the detection rate of chromosomal abnormality like Down syndrome. Maternal age alone as a parameter has a detection rate of only 30%. When we combine maternal age with nuchal translucency, the detection rate increases to 75%. But when we combine maternal age with ultrasonographic markers and biochemical markers like PAP-A and beta-HCG, the detection rate increases to 90%. So combined test is gold standard test these days for aneuploidy screening. NIPT is again another screening test in which we look into the cell-free fetal DNA, which is obtained from maternal serum. But we have to remember that this is just a screening test, but with a high accuracy rate, up to 97% for three most common aneuploidies, that is trisomy 13, 18, and 21. Preeclampsia screening can be very well done in first trimester of pregnancy by the measurement of uterine artery Doppler. And whenever we find women with high risk for preeclampsia, incorporation of aspirin has reduced significantly perinatal as well as maternal morbidity. Screening of preterm labor is done by transvaginal assessment of cervical length, and this is specifically recommended in women with previous history of cervical incompetence, preterm birth, cervical surgery, and multiple pregnancies. We have prenatal invasive testing like chorionic villus sampling, amniocentesis, and chordocentesis, in which we try to get some tissue. In chorionic villus sampling, we get the tissue from placenta. Amniotic fluid will be taken in amniocentesis, and fetal blood is sampled in fetal blood sampling or chordocentesis, because the genetic material which we get from these testing is equal to the genetic makeup of the baby. It helps in diagnosing and eliminating certain genetic disorders. This is amniotic fluid sampling, and here we can see the sample is being taken from placenta of the chorionic villus biopsy. Coming to fetal reduction, because these days we are having more of IVF conceptions, we do get higher order pregnancies. So in such cases, we offer selective fetal reduction. This here in this clip we can see, this was a fetal reduction which was offered to a couple who had triplet pregnancy. Unfortunately, one was monochorionic pair, and we had to reduce monochorionic pair and continue it as a singleton pregnancy. But here, this pregnancy was seen in the uterine wall. So instead of taking her for surgery, we offered them embryo reduction, and in both the cases, potassium chloride was injected. So, and they continued on. This was a case when a patient was referred to me at 24 weeks for fetal hydrops. On evaluation, we found baby was having fetal anemia. So intrauterine transfusion was offered. Then baby was delivered after 35 plus weeks, and baby is doing fine now. And this is one more primary patient who was having monochorionic diamniotic twin gestation, but unfortunately one fetus had Epstein's anomaly and was showing hydropic changes, and this could have impacted the health of the other fetus. So after discussing with the patient, with the prospective parents, we offered them radiofrequency ablation of the unhealthy fetus, and so hence after 24 weeks they continued as a singleton pregnancy, and this woman delivered after 37 plus weeks, and the baby is doing fine now. Genetic testing, in which we look into the variations of the DNA. Pre-conception genetic testing is important tool for couples whose genetic makeup might have negative consequences on their children's health. So it can be done either by targeted screening or expanded carrier screening. I do understand fetal health issues are very complicated ones, but with the use of adequate technology and the advancing techniques, we can really reassure prospective parents, and we can really try our best to give a child a better outcome, a healthy outcome, in fact. Thank you for your kind patience and time.
Thank you, Dr. Shaheen, for that quick and full coverage of the fetal medicine. It was a bit going very fast, but for the crowd like this, it was too fast to understand. But she has covered everything from the first trimester onwards and the importance of screening. And without a fetal medicine specialist, no obstetrician can survive now without their help. Previously, we were all using our fingertips, whether palpation or vaginal examination, to decide many things, but it's all gone. She said about the inverted pyramid, which means initially, earlier times, we were having fewer examinations the first trimester, earlier part of pregnancy, and many of the examinations were shifted to the last period where complications will appear. Now it is the reverse. That is what she mentioned about the inverted pyramid. You concentrate on the first trimester. See the possibility of the complex problems developing the later weeks of pregnancy, both for the mother and baby, by this proper investigation and predictive tests. She mentioned about the hyperonucleoids, who was the father of this specialty as such, who is working decades together. He is at King's College, London, yes. And he has produced certain standards and which has revolutionized the practice of obstetrics and gynecology and fetal medicine as such. You know the Down syndrome, the babies may survive. They may have many challenges for that family and for the baby. So those who want not to have such a baby can opt to terminate that pregnancy, but you should not be terminating a normal fetus. You have to identify properly at the correct time as early as possible so that the termination as such will not become so dangerous. The second time beyond, it becomes more complicated. So you confine to first trimester screen. She said about the nuchal translucency and so many other things. You can predict almost 90% with accuracy of 10% false positive rate of predicting Down babies. Structurally, they may look normal. By ultrasound scan, you may have some soft markers, what is known as some changes here and there, like absence of nasal bone and other things by scan. But if you put everything together, almost 90% prediction is possible. And those people are given. The next option she said about the NIPT, non-invasive test, which is cell-free DNA circulating on the mother's blood. It is come from the placenta, from the component of the baby. It is circulating as a DNA particle. Now we have got test to get the sample of the maternal blood. You do the test, the fetal fraction is identified, and you can identify many of these conditions. That is another branch which she has mentioned. So with all those things, you will be able to predict such anomalies and abnormal babies earlier and concentrate on to them. She said about the preeclampsia prediction, which is the second important cause of maternal mortality in our state, in India, in any part of the world. So you can reduce it by, also mentioned about the prophylactic aspirin during pregnancy if you predict it in the first trimester itself. It is effective in the first trimester, not later on. So all those things are covered very well. Thank you for telling. If at all there is any clarification needed, she is ready to help us. So.
Thank you, madam. That was an excellent talk. Being an obstetrician and gynecologist working in the periphery, the first thing we do is a first trimester scan, then around 11 to 13 weeks of an NT scan and double marker, anomaly scan 5th month, and then the final scan. This is the usual pattern we follow for all patients. Do you think that anything else should be added to this? Because initially, maybe about 20-30 years ago, scan തന്നെ ചെയ്യുന്നത് തന്നെ ഒരു എന്താ എന്തിനാണ് സ്കാൻ എന്നായിരുന്നു ചോദ്യം. ഇപ്പം പേഷ്യൻസ് ഇങ്ങോട്ടേക്ക് വന്ന് ചോദിക്കുകയാണ്, സാറേ 3-ാം മാസത്തിൽ സ്കാൻ ചെയ്യാനുണ്ടല്ലോ, 5-ൽ ചെയ്യാനുണ്ടോ, അങ്ങനെ. സോ ദിസ് ഇസ് ദ പാറ്റേൺ ദാറ്റ് വി ആർ ഫോളോയിങ് ഇൻ ദ പെരിഫറി. ഡു യു തിങ്ക് ദാറ്റ് വി ഷുഡ് ബി ആഡിങ് എനിത്തിങ് മോർ ടു ദിസ്?
Thank you, sir, for asking this question. Yeah, these 4 scans would be standard protocol in periphery, especially in low-risk women. Any high-risk women would require little more prenatal care and little more of close monitoring of maternal and fetal health. So scans can be customized as per the underlying situation. As you said, double marker, I would prefer telling like adding NT scan along with the ultrasonographic markers and PAPI and beta HCG, which is nothing but double marker. So that is called as a combined test instead of doing double marker alone, because double marker alone has positive predictive rate of only 70%. But when we add all these markers, anyways we are doing scan and we have maternal age. So when we add the biochemical screening to this ultrasonographic markers, we get a positive predictive rate of 90%. So that would be a better marker, I mean like better biochemical screening these days.
It's a combined test. You add everything, your prediction will be maximum. Actually, in adding the nasal bone also, which they will be doing, will reduce the false positive rate 10 times less. If it was 5% otherwise, can be reduced to 0.5% false positive rate. Now, that is the beauty of adding these simple things, which they will be doing routinely, nasal bone. So, you ask for the combined test, they will be doing everything. You naturally, those who are doing the serum markers, the PAPI and other things, will be adding the maternal age, weight, race, diabetic or other things are to be added to get the final result or the prediction of what is the thing. And what you call it as a positive or risky, what is the ratio that you take? I mean 1 in...
So cutoff we take as 1 in 100. If anything is less than 1 in 100, we offer further testing for confirmation, because all these are only screening tests. They do not confirm the baby is having Down syndrome.
So counseling is important. We have to be told that this is only screening. If you follow, the screening means whether you are having high risk or low risk, that's all. If you are at a high risk, you have to have confirmatory testing. And if you are not willing for termination of, if it is unfortunately Down syndrome baby, then there is no point in doing it at all. So you have to counsel them properly. If you go for the screening, if it is found to be high risk, you have to for the confirmatory test. And unfortunately, if it is positive, are you willing to terminate that pregnancy? If not, why to undergo all this trouble?
Yes, sir. Pre-test and post-test counseling are very important, and we have to be very choosy in our words, because I've seen little bit of more counseling, they just go and terminate the pregnancy. They just don't want to confirm the thing. And on ultrasonography, we look the markers like ductus venosus flow, tricuspid regurgitation, along with nuchal translucency and nasal bone. So these are the markers when we add and do combined test. All these markers, addition of markers, decrease the false positive rates. So that's the use of adding all this and doing combined test rather than doing only PAPI and beta HCG.
And my issue is that doing this combined test in a peripheral hospital may be a problem. കാരണം വെച്ചാൽ അത് അത്രക്കും സംവിധാനങ്ങൾ ഇല്ലല്ലോ ഞങ്ങൾക്ക് പെരിഫറി.
If you are sending for a scan, if you believe in doing the first trimester scan, that scan should be properly done. That's all. The people are to be trained. Online there is a training by necroids and others. They have to have submit so many images to say that they are competent to do the NT scan. So there is an online program running on to have the qualified people. Just getting MD or MS is not sufficient to do all those things. There should be a accredited thing, and it is all going on. All these programs are going on. They are all accredited. Apart from their degree, they are all accredited by these international associations, both ISCOG and otherwise Fetal Medicine Foundation. They are all undergoing this thing. And if you are sending for a scan, that will be properly done. At least one scan. If you need not go for the 8-week scan. If there is no problem, nothing is there, you confine to the 11-13 weeks so that you get maximum information at that time for all those things, including prediction of preeclampsia, prediction of so many other things. So even IUGR later on, that also predicted in the first trimester. Even macrosomic baby can be predicted by their help. So if you are believing in ultrasound, do it properly.
Thank you very much, sir. Thank you, Shaheen, madam. Kindly accept this memento from IMA Kozhikode. Thank you. I call upon Dr. Jayachandran sir to hand over the memento to Dr. P.K. Shekharan. We move to the next session. I call upon Dr. T.P. Ashraf, Professor, Head of Department of Pediatrics, Government Medical College, Manjeri, to chair this session, along with Dr. Anand, Senior IMA Leader.
Thank you, Dr. Raju. Next session is Commit to be Fit. The session is taken by an apt person to talk on that subject. That is Dr. Roy R. Chandran, Professor of Physical Medicine Department, Government Medical College, Calicut. We all know Dr. Roy. We all know him. He needs no introduction to this audience. As a medical teacher, as a leader of Indian Medical Association, he's a very committed person. He's having many hobbies. He's a sportsman. So I said he's a apt person to talk this. Many hobbies, including Kavita, Chollale, recitation, cartooning, drawing. He's a cricketer. He was the Kala Pratibha of Trivandrum Medical College many times. And the topic is also important. We doctors are good preachers, but not a good practitioners of many things for us. That is the topic. Over to you, Dr. Roy.
Thank you, Worship Sir, for the kind words. Respected chairs, my teachers, seniors, and friends. Robert M. Hutchins, he was a chancellor of Chicago University. He made a statement in 1970. Whenever I feel like exercise, I lie down until the feeling passes. He made a funny statement, but this statement actually coincided with an era of lifestyle diseases, change in food habits and lack of exercise, and in late 1970s, 1900s, the main killer of humans become the lifestyle disorders, displacing the infections. The gurus were advising regarding the importance of food and exercise from the beginning of medicine. This was a quote by Hippocrates, the father of medicine. Food and exercise are your medicine. Still, we are advising. This is a new ACSM, the American College of Sports Medicine guideline regarding exercise guidelines of adults. There are similar guidelines by American Diabetic Association, the National Diabetic Federation, American Heart Association, etc. But where are we now? This was a study conducted by IMA Pune chapter. It was published in 2010 in an online journal, DNA. An average Indian lives up to 69 to 72 years, whereas a doctor lives only up to 55 to 59 years, which is shocking. It was noticed that most of the early deaths were due to cardiac arrest. There was a similar study by IMA Kerala State when Dr. B.G. Pradeep Kumar was the president in 2017, which has shown that the average lifespan of a Kerala doctor was 62 years, when the average lifespan of a Keralite was 75 years. So that is the importance of this session. We should take care of our body. It is the only place we have to live. We should get committed to be fit because the society need experts like you for years in good health. So be healthy for our nation. Unfortunately, this topic is not relatively, but grossly neglected, not only by the patient, but also, unfortunately, by the doctors. The statistics, India has got a dubious distinction of the diabetes capital of the world, the hypertensive capital of the world, the capital of the cardiovascular disorders, etc., etc. And we are on the second place when obesity statistics is concerned. The US is on the top and China on the third. Coming to Kerala, the place where scenic beauty is there. This is a 2007 National Family Health Survey. We are on second place when obesity is concerned in 2007. 25, that means 1/4 of our Kerala males and 1/3 of females were obese. This is the next latest survey, the National Family Health Survey 2020. From 33%, the obesity raised in females to 38%, and from 24%, the increase in obesity in males was 36%. Hypertension was seen in 31% of females of Kerala and 33% of Kerala males. Excuse me. And diabetes is in 27% of females and 25% of males. And anemia is seen in 36% of females of Kerala. That means we are becoming obese and malnourished. And that is seen only in 18% of Kerala males. See, you know that we are on a war against militants. The government says our forces are ready to deliver any time, and seems they are not bluffing. See, we should start a war against lifestyle disorders. Before going to the solution, we should see what is the problem. Why? What is the reason of the dramatic increase in lifestyle disorders? One is definitely the sedentary lifestyle. Now, sitting is considered as new smoking because every hour of sitting, we do cut about 22 minutes from our lifespan. That means after the end of IMAAMSCON 2023, we will be happy to decrease 1 or 2 days from your lifespan. So smokers shorten their lives by about 11 minutes per cigarette. The second thing, this is a fact that when the household items get slimmer, the users will get fatter. Previously, we have got malnutrition. Now we have got malnutrition, the nutrition we got from the mall, the fast food. Yes, you will become what you eat. We'll go to two usual case scenarios we encounter in our OPs. Case 1, a 30-year-old teacher, sedentary, she considered household activities as exercises. She complained of generalized aches and pains, easy fatigue, increased appetite, gradually increasing weight, and all the investigations were normal except increased triglycerides, and there is no signs of depression. And case 2, a 28-year-old male, he spends 4 hours in gym daily. He also had similar complaints of generalized aches, pains, frequent injuries. Investigations were similar except increased triglycerides. He also have no symptoms or signs of depression. So both of this person are having the similar complaint. One seems fit. He spends almost 3 to 4 hours in gym daily, and the other person is totally sedentary. But the complaints and the clinical examination as well as the investigations are normal. And what is this physical activity and what is exercise? Are they same? See, the physical activity is a general term that includes all movements using muscles that utilizes energy. That means that increases the energy utilization. That means exercise, running, walking, etc., and household activities, etc., etc. Everything which utilizes muscles and increases energy uses physical activities. But exercise is a more specific form of physical activity that is structured and designed to improve the physical fitness. The benefits of exercise, I won't go to the details. You know all the benefits of exercises. Even that can prevent cancers. The latest thing is that can correct the colonic microbiota dysbiosis, which is a problem in many of the inflammatory conditions, including inflammatory arthritis, even in osteoarthritis. And I will focus on the last, the weight control. Exercise and weight loss, is exercise essential to reduce your body weight? We usually advise patients regarding minimum 30 minutes of brisk walking or sort of exercise daily. 30 minutes of exercise like brisk walking will burn around 100 to 200 calories according to your body weight. The next question from most of the patients should be, why should I do exercise? Many have got this syndrome, the common syndrome, now the idiot syndrome. That means the internet-derived information obstructing the treatment. And most of them have some idea about everything. So the questions like this means, and 30 minutes of exercise will burn around 100 to 200 calories. Can I avoid at least 2 teas, two vadas or 2 chapatis, which contain almost 100 to 200 calories? Why should I waste 30 minutes from my busy schedule? What should be your answer? The persons are also confused due to the ads on obesity. I realize the importance of apostrophe after seeing this ad. This is Anus, nothing else, finger licking, pocket loving, and good food. So the ads sometimes confuse you, like this ad on Fair and Lively. Ads on obesity will definitely confuse you. This was a hit in Kerala, Levana Thailam, a decade ago. This is an oil, just apply on your areas which increase fat, and the fat will melt. That is ad. And now we have different sort of belts. Just put on the abdomen. You will feel that you are not obese. And some slim centers like this, 3 kg loss for 30K, 5 kg loss for 50K. Some give offers, New Year offer, 1.5 kg loss free. See, what is the importance of exercise? This person says, my low-fat diet really works. The fat hangs lower every day. Is it true? Is it true when you are on fat alone, the obesity will increase? Yes, the answer is yes. See, if you are on diet alone, what happens? Like, for example, a person a 70 kg person start to reducing, in the idea of reducing weight, he was on diet alone without any exercise. What happens? So there is a lipostat in our body, like thermostat or glucostat. The body will resist change in fat size. So if this person start dieting without any exercise, what happens? There is a homeostasis in the body. The body will resist in the body, the 70 kg. So what is the first trick? First trick by the body is to increase appetite. So the body will increase the strongest orexigenic hormone from the gut, that is known as the ghrelin, that will act on your ventral lobe of the hypothalamus, and this person will have an irresistible urge to take food. So if the person conquers that appetite, the next trick by the body is to reduce the basal metabolic rate. The person will have increased fatigue, decreased activities, etc., etc. And if the person is continuing on the strict diet and even the food intake is not enough to maintain the basal metabolic rate, what is the next thing will be taken? What the next thing will be taken by the body to maintain the BMR? Is it fat? No, that is protein. That is protein from the muscle mass. As you know, the liver and the skeletal muscle is the most important organs is for maintaining the metabolism. If you lose muscle mass, what happens? There will be increased fat mass. So decreasing in lean mass, that means decreasing the muscle mass will increase the percentage of body fat and increase in insulin resistance and impaired glycemic status. So actually exercise is not to reduce your body weight. It is actually to maintain the muscle mass at a higher level and to maintain the basal metabolic rate. Now I will be going to another thing, some bit boring thing, the science of exercise, back to the physiology days. Please don't sleep, because this is the most important message I want to convey. So as you know, there are three major energy systems in our body. One is the ATP-PC system, second is the anaerobic glycolytic system, and third is the aerobic system. And the ATP-PC system is for emergencies. The phosphocreatine and ATPs are stored inside the body. That is anaerobic. And second is the anaerobic glycolytic system. The glycogen is the fuel source. So that happens in the type 2 muscle fibers, which is totally anaerobic. The lactic acid is produced as a byproduct. The third, the most important system, is the aerobic system, where glucose as well as fat can be utilized. It is burned inside the mitochondria in the presence of oxygen. And this is the most important system. I'll come to it. We have got two types of muscle fibers. Type 1 is a red muscle. The oxidative things happen in here. The anaerobic metabolism happens in the type 2 muscles. This is the most important message I want to convey. The glycogen, the form of glucose, when it is burned anaerobically, will give you 4 ATPs. 2 will be used during the process, and the resultant will be 2 ATPs. And glucose, when burned aerobically inside the mitochondria, will give you 38 ATPs. 2 will be again used during the process. The 36 will be the result. But free fatty acid, according to the chain size, will be burned in the mitochondria and will give you 140 to 150 ATPs. Keep this in mind. And coming back to the exercises, usual question is, will exercise add years to the life? That means, will exercise increase your lifespan? So several studies like this have shown that an exercising person will have 10 to 20 years, not 1 to 2 years, 10 to 20 years more life than a sedentary person. $1 million question will be, will it add life to the years? And what is the importance of adding years to the life when there is no life in the added years? Regarding the quality of life in the added years. Again, the researchers have shown that an exercising person will have 10 to 20 years more life than a sedentary person. And this person will be active, at least in his or her ADL, activities of daily living, until his death. So he will be independent in the added 10 to 20 years. So we'll begin regarding the exercise. This is the American College of Sports Medicine exercise guideline for adults 2020. We need 4 types of exercise. The first 2 is must. The last 2 is optional. One is a cardiovascular exercise or aerobics. Second is a resistance exercise. Third is a flexibility exercise. And fourth is a neuromuscular exercise, which will increase your balance. That is optional. Questions, are we advising, giving advice on exercise? Are we? No answer. If yes, are we giving the correct advice? If yes, are the patients or we doing it correctly? See, we will come to the first thing, the aerobic exercise. These are all aerobics, walking, running, games, Zumba, cycling, dance, etc., etc. Everything is aerobic, but all this can be done aerobically or anaerobically. This is a recommendation. We should engage in 150 minutes or more of moderate intensity aerobic activity per week, spread over at least 3 days a week. So definitely there is a confusion ahead. What is this aerobic? What is this moderate intensity? So aerobic exercises are defined as that which uses large muscle groups rhythmically for a period of 15 to 20 minutes or more, while maintaining your heart rate between 50 to 70% of maximum. This is a definition. Which are the physiological adaptation, why this is known as cardios. So when you have aerobic fitness, when you are exercising, what happens in the muscles? There will be increased capillary density. That means there is more vessel formation, more angiogenesis, increased myoglobin, increased size and number of mitochondria. There will be vasodilatation so that the muscles can utilize maximally the fuel provided to them. The fuel is oxygen. So what happens in the heart? There will be increased preload because when you are fit, you will have some muscle hypertrophy, or the peripheral muscles, the peripheral heart can act more. So there will be increased preload, that is a venous return. Second, there will be a decreased vascular resistance because there is angiogenesis. There will be more vessel formation. And you know that according to the Poisson's equation, the force exerted is inversely proportional to the fourth power of radius. So if there is more vessels, the heart can reduce the force. So there will be reduced afterload. So the heart can increase the stroke volume. There will be decreased heart rate because the muscles are utilizing more oxygen. So that is this is the ideal environment for the heart. So increased preload, that is a venous return, decreased afterload, that is the peripheral resistance, and the increased diastolic period due to the decrease in heart rate. So this is the most ideal environment for the heart to act. So this is why it is known as cardios. So this is aerobic conditioning. So coming back to that important slide, the efficiency, the glucose will give you 36 ATPs when burned aerobically inside the mitochondria, and the free fatty acid will give you 140 to 150 ATPs. So aerobic fitness also means your ability to utilize free fatty acids as a main energy source. So if the free fatty acids are giving you 140 to 150 ATPs when burned inside the mitochondria in type 1 fibers, that is aerobic fibers, if you have aerobic fitness, your appetite will come down. Your appetite will come down because this free fatty acids are giving you enough energy. Your craving for glucose will be reduced. Your body won't be storing more triglycerides. What happens? So the appetite will come down. There won't be craving for glucose-rich food, and there won't be triglyceridemia. Okay. Coming back to the case number 1, the sedentary teacher who considers household activities as exercise, who complained of easy fatigue, increased appetite, increased weight, with abnormal investigation, just one with high triglyceride, with no signs of depression, was suffering from what is known as the aerobic deficiency syndrome, probably the syndrome of the century. So aerobic deficiency syndrome is a syndrome when the aerobic system is not well developed and maintained. That's a major risk factor for lifestyle diseases. These are the symptoms, similar symptoms, fatigue, generalized aches, etc. See, we have got two types of muscles, as I already mentioned. The type 1 muscle, 80% is a red muscle, the type 1 muscles, where the aerobic metabolism happens. 20% is the type 2 muscles, the anaerobic muscles, which is meant for emergency. So this emergency, the muscles meant for emergency will be active always. But this aerobic muscles, which is the 70 to 80% muscles, will be in a inert state until it is trained. So that will get switched on only with proper training. That is the importance of aerobic training. Coming to the exercise prescription, most of our patients are, especially in Kerala, do what the doctor says. This patient, the doctor asked me to spend at least 1 hour per day on the treadmill. She was very, very compliant. Why not? See, an exercise prescription should be tailor-made. The consideration should be given to the needs, work schedule, hobbies, interests and skills, and ability and the financial capacity. See, the dictum is what one has not done for a lifetime cannot be accomplished overnight. So the thing is, start slowly and go steadily. Coming to the intensity, if someone describes aerobic exercise as a series of strenuous exercise which help convert fat, sugars, and proteins to aches, pains, and cramps, means you are doing it wrongly. See, this is a formula for calculating the maximum heart rate. 220 minus your age is the maximum heart rate. If you are on beta blockers, there is another formula, 160 minus 0.7 into age. So for a 20-year-old, the maximum heart rate will be 200. So start with 50%. That means for this 20-year-old, the 50% will be 100, and increase up to the desired level, that is 70%. That means for the 20-year-old, between 100 and 140. That is a desired level of aerobic exercise if you want to get aerobic fitness. If you cross this level, you will be exercising anaerobically, then you'll be getting only anaerobic fitness. That is why I said in the initial slide, aerobic exercise can be done aerobically or anaerobically. So if you cross the 70% mark, then you'll be utilizing your anaerobic fibers only. So for assessing the intensity, you can utilize the smartwatches, or for laymen, there is a simple thing that is known as the talk test. That means mild means during exercise the person can sing. That means you had reached just the 50% of maximum heart rate. The moderate, the desired thing is a moderate heart rate. That means you cannot sing, but you can talk during the exercise. That means you are now at the 50 to 70% of maximum heart rate. So if you cross it, vigorous, that means you cannot sing, you cannot talk, but you can say only words. So there are few phases of aerobic exercise. One is the warm-up phase. Warm-up phase is stretching, right? That is not stretching. That is a first step of exercise. That means increasing the heart rate from the resting value to the desired level. Okay. That means the first 5 to 15 minutes should be meant for warm-up. So A is the warm-up, B is the exercise proper, and C is what is known as a cool-down. Cool-down is a final phase where you have to decrease the pace so that the heart rate will reach in 5 to 15 minutes to the near normal resting rate. Okay, so this can prevent pooling of blood in the muscles. This can prevent post-exercise cramps and edema. So coming back to the recommendation, this is the recommendation by IID and American College of Sports Medicine. Engage 150 minutes or more of moderate intensity exercise, or 30 minutes of exercise per day. So the moderate, that is the moderate is a key. That is, this is not 150 minutes of walking per week. That is 150 minutes per week of moderate intensity aerobics. That means the B is 150 minutes, or if you are exercising 30 minutes per day aerobically, there should be 5 to 10 minutes of warm up, and another 5 to 10 minutes of cool off. So total section should be 40 to 50 minutes. Okay. The last thing, the resistance training. Do we need resistance training? Yes. The answer is yes. The thing is that after the age of 30 years, 5% of muscle mass will be lost per decade. And after the age of 65 years, it will be 8%. So resistance training will help you in preventing the muscle mass. So the resistance trainings involve exercise which involve using external weights or your body mass as resistance. So these are the equipment we need. You can go to the gym or you can use equipment like this, a TheraBand, dumbbells, or a chair for balancing. So exercise with TheraBand. Coming to the case 2, the 28-year-old male who spends 4 hours in gym with complaints of general exercise pains with hypertriglyceridemia is suffering from what is known as the syndrome of anaerobic excess. The syndrome of anaerobic excess, there is an imbalance of aerobic and anaerobic systems, more utilization of aerobic fibers. So the main fuel is glucose. For this person, there will be increased appetite, increased craving for glucose-rich food. There will be hypertriglyceridemia, and there is high chances of cardiomyopathy. Who is this actor? Puneeth Rajkumar is a Kannada actor. He died in 2021 October due to arrhythmia due to this anaerobic excess and cardiomyopathy. Coming to yoga, these are the types of exercise we need. Yoga combined everything except aerobic exercise. So yoga combines resistance, flexibility, and balance training, but not aerobics. So you can do yoga after doing aerobic exercise, that is enough, but not doing yoga alone will not give you fitness. Avoid things like Shirsasana or Sarvangasana because the person will reach Shavasana. Going to the precautions, never start high impact activities like treadmill initially because this may injure your weight bearing joints, back, knees, or ankle. Similar things can happen with elliptical trainer, the orbic tract, skipping, etc. So the good thing, if you have pain of your weight-bearing joints like knees, ankles, or back, is cycling, walking, or swimming. So Mammootty is one person who conquered aging with proper lifestyle modification. He turned 72, crossed 72 last month. And the trawler says this will be the scenes of Mammootty in Dulquer Salman's daughter's marriage. Rekha is a lady Mammootty. He will be becoming 70 years in 2024. This is my take-home message. The secret of staying healthy and young is to properly exercise, move a little more, eat a little less, and lie about your age. And you cannot advise persons like this, patients, you're obese. We should be leaders to create a healthy road for others to follow proper lifestyle. And we can help others in exercising like Nannan Okas once said, if a young woman goes for a walk daily, she improves the health of 10 men. And this is a quote by Sir William Osler, the father of modern medicine. One of the first duties of the physician is to educate masses not to take medicine. That means our main duty is preventing diseases in patients. And thank you very much for the opportunity, and thank you very much for the hearing.
Thank you, Roy sir. It was a very lucid, informative, and thought-provoking session. it's an irony that I was called upon to chair this session because I will have to put X into all the parameters for a healthy and quality life. Hope this talk of yours will initiate some of us into getting into a better lifestyle.
Thank you, sir.
I thank you, Roy, sir.
Dr. Roy, it was an excellent session in simple words. Session is open for discussion. Any points, any comments from audience? If there is no comment, yeah. Raju, mic on order.
Balance exercise, sir. Balance.
Dr.
Balance
Pradeep.
exercise. That is meant for those who have increased chances of fall, like neurodegenerative disorders, balance problems, etc.
Not
Balance
for,
training.
But not for a healthy adult.
You can do, sir. That is optional.
You mean yoga or any particular?
Yoga will combine that also, sir.
There is no more questions. We will conclude the session. Once again, thank you, Dr. Roy, for that excellent
Thank you,
session.
Dr. Roy. I request the chairpersons to hand over the memento to Dr. Roy. I request Dr. Jayachandran, sir, to hand over the mementos to the chairpersons. Thank you. We move to the next session. I call upon Dr. Chandri Madam, Department of General Medicine, MCH Kozhikode, to chair this session.
Good afternoon, and this is the last session, but it's going to be a dessert. And speaker is Dr. Joe George. I'm very happy to introduce Dr. Joe George. And he's a senior consultant endocrinologist, and you must be knowing endodiabetes across Kerala and outside Kerala. It's expanding. And he has made he has been in various organizations, and he has been instrumental for many of the excellent conferences. He was the former secretary of Endocrine Society of Kerala chapter, and he is currently the governing body member of our Research Society for Study of Diabetes in India, Kerala chapter. And he's the best postgraduate student at KEM Hospital. I'm very proud to introduce Joe, and he's going to talk to us a very important common topic, common confusions in evaluation and management of thyrotoxicosis. Over to you, Joe.
Thank you. Thank you, Madam, for the kind introduction. As it's just a pre-lunch session, I will just go through it rapidly. It's a common and very confusing area of thyroid management, that is the management of thyrotoxicosis. I don't have any of interest, though this session is sponsored by Sun Pharma. I feel they don't even know the topic name, so that's the way they have done it. So there's no conflict of interest actually. When you think of thyrotoxicosis, sometimes as we see in the textbooks and as we see in the descriptions that's given in the textbooks, certain things are very straightforward. Like this 24-year-old lady who is coming with restlessness, fatigue, irritability, labile moods, weight loss, loose stools, heat intolerance, palpitations, having on examination being hyperkinetic, pulse that is having 102 with a warm moist skin, diffuse goiter, prominence tear. You don't even need to ask any symptoms to this lady. When she walks into the OPD, you know that it's Graves' disease. So sometimes it's very simple, but that's not always the case. You can see 3 people who have been diagnosed as having thyrotoxicosis, and of which the first person would be quite familiar to at least the older generation, may not be the younger generation. He was a US president, and looking at him, he doesn't have any symptoms. And like the last person who is there, elderly person, he looks more like a hypothyroid rather than a hyperthyroid. So, though the classical description of thyrotoxicosis is something different as given in textbooks, we do see that kind of patients. But the common scenario is like this patient who comes with a 35-year-old lady who comes with irritability and labile moods, no goiter on palpation, no tenderness, and because of her irritability, she would have gone to some doctor who would have advised some package. Sometimes she would have by herself gone to a lab. Nowadays, everybody propagates these packages. And on doing the package, she found that her TSH is slightly suppressed, less than normal. T3, T4 is in the normal range. Then things become different. We don't know what to do. Is it something that need to be treated, or is it just a lab error, or is it just a common anomaly, or something that can recover by itself? So when this kind of scenario happens, then the thyrotoxicosis management from the doctor's perspective takes a different view, where you are even confused after taking the full history and examining the patient, because you don't see anything. No goiter, no tachycardia, no symptoms, just irritability, and this, she has done lab, which even I often think that if that patient had walked into my OPD as a patient directly, I wouldn't have even ordered a thyroid function test. So that's a scenario. So then we have to think from a different perspective, where we think of why does the TSH get suppressed? And when you think from that perspective, the common reasons, I'm not going into the whole reasons. The common reasons are thyroiditis, early Graves' disease, because I'm not saying the frank Graves' disease because it's just a mild suppression. So it could be a thyroiditis, it could be early Graves' disease, it could be a toxic multinodular goiter. You don't need to palpate the nodule always. Sometimes the nodule may be inside, which you may be able to recognize only by ultrasound. So toxic multinodular goiter, a toxic nodule, or sometimes it could be drug-induced. There are a lot of drugs that can produce some TSH suppression, and sometimes it may even be a lab issues that is the problem. So the question would be what to do when a patient or who doesn't fit to the typical clinical practice where you take the history, examination, make a diagnosis and manage. Here you have to go through a different pathway, which is to go by investigations. One of the common the way we proceed is to go for a technetium thyroid scan in this case, because you don't have any symptomatology. You need to identify from the single most likely cause from the differentials that I have already given. So here comes the use of technetium scan. So technetium scan gives you 2 ideas. One is on the imaging pattern, like the structure, function, type of toxicity, whether it's a function nodule, toxic multinodular goiter. And also it gives you the diagnosis of thyrotoxicosis, like to confirm the diagnosis, the amount of uptake that's there. And also it will be able to differentiate within the causes of hypothyroidism. So when this lady walks in with the mood lability and irritability, what do? Do you straight away go for the technetium scan? Ideally, yes, but you should wait. Why should you wait? Because did you miss something? Did you ask her when was her last period? Because this kind of suppression of TSH can happen with early pregnancy also, where the free T4 may remain normal or even slightly elevated, but the TSH may come down because of the HCG effect. So in ladies, especially ladies, they may even say, there is that, I don't think I can get pregnant at this point. That is what they feel that they are. But finally, if the husband is there and living together, I think you should always do a UPT before proceeding with technetium scan, because it's a very common occurrence that happens. So as I already mentioned, TSH can be suppressed in the early pregnancy because of the HCG effect. So that is something to be ruled out before proceeding to the further investigations. Then the only thing that you can do here is to either clinically monitor the patient, which often nowadays patients don't want. They want quick results, quick answers to the question. If I tell them that, see, this is a very mild disease, it may recover, it may proceed and become high, what we'll do is we'll wait for 2 months or 3 months and then do it. One thing that I've recognized in my common practice is that most of them don't turn up. Sometimes they they may be going to another doctor, or sometimes they just don't follow up also. So it's always better to have a clear-cut diagnosis, at least initially itself, so that we can give them a proper guidance. And nowadays, everybody wants quick results and quick answers to the questions. They don't want to wait for 2 months for a simple answer. So technician scan, when you do it, you can get various kinds of picture here. Though the TSH is only mildly suppressed, the uptake may be increased. Like this typical butterfly-shaped gland with an increased uptake, that is 30%, suggests of a Graves' disease. So you have made a diagnosis of Graves' disease there. Sometimes there may not be any uptake, like a 0% uptake, where the gland itself is not at all visible, which can be happening in the case of a thyroiditis. So it's very simple. But again here, it can be confusing. Like a person who comes with a diffuse, this kind of an uptake, but only 3% uptake. Then it may be a doubtful scenario, confusing scenario. Is it a Graves because the pattern looks like Graves, but the uptake is not increased? Why? That is confusing. There again, you have to go back to the clinical history, where it's just a mild irritability in mood, nothing like that. So it may be just a recovering phase of thyroiditis. During the recovering phase of thyroiditis, the uptake may not be increased, but the pattern of increased uptake may be seen, but it may not be increased. So the same picture may suggest Graves and also thyroiditis, recovering thyroiditis, while the typical thyroiditis is something that you see here. It's right side. Okay, so other pictures can also happen in technician scan, where the first picture is that of a nodule. It's a hot nodule, very simple diagnosis. But sometimes the second picture also is actually the only very mild increase in uptake. You can see that on the left side, there is only a very mild increase in uptake. But corresponding to that slight increase in uptake, there is a nodule in ultrasound. So you can make a diagnosis that it's probably a warm nodule, which is producing that mild TSH suppression. Like in the third case, where again looks like a very diffuse uptake, you can see that arrow, where there is a slight defect, which on ultrasound may be showing a nodule. So that means it is a case of Graves' disease with a cold nodule. So often what the common mistakes that happen, confusions that happen is, like even if you're palpating the swellings, you don't need to always take a conclusion that the nodule is producing the increased hormone. Sometimes it may be that the gland is producing increased hormone and the nodule may be pre-existing or maybe just a cold nodule. In the same way, thyroiditis, I told you, thyroiditis can produce a very difficult clinical picture at times because the patient may not be always symptomatic. So in those cases, like we know that this diagram is there in Harrison's and also in Davidson. So initially, in a typical phase of thyroiditis, clinical phase, there is a hyperthyroid phase followed by euthyroid phase, then again hypothyroid phase, then 20% remain hypothyroid and 80% recover. So this kind of a fluctuating TFT can happen in thyroiditis. So what happens? Like this picture of TSH suppression can happen in thyroiditis. This kind of a slight suppression can happen in the early phase of hypothyroid, where the TSH is 0.1 with the T4 that is slightly lower. And this blue actually shows the T4 is high with the typical picture of Graves, but it's a thyroiditis in the hyperthyroid phase. But if you do a technician scan, you can get a 0% uptake. While the second case, when you do a technician scan, you typically get that TSH is mildly suppressed, but the uptake may be something like what I mentioned of 3%. Mild uptake may be there, where they may even suggest that it's an early Graves. The report may suggest early Graves, but it's just a recovering thyroiditis. Then the patient may have a hypothyroid and also a euthyroid status when it recovers. So also depends on the biochemistry, also the clinical features and also the technician uptake. Here what you should understand is that in the early phase of hypothyroid phase, that thyroiditis, the uptake is low, but in the second phase, the early hypothyroid phase, when the TSH is still suppressed, the uptake is increased or slightly increased, not very much increased, but slightly increased. So it's always proper to have a diagnosis in suppressed TSH or thyrotoxicosis before starting treatment. It's a common mistake that I see, that when you see a suppressed TSH, the first tendency is to go for a neomarcosol treatment or carbimazole treatment. In the same way, when you see a nodule in thyroid or in the neck, the first tendency is going for an FNAC thyroid. Actually, that's not the right way, because when you go shortcut the pathways,
then looking back, things become very difficult to analyze also. So it's always better to go in the right pathway. Like when you have a TSH suppressed, go for a clinical evaluation, then for the proper investigations, because before starting treatment. Why? Because these are the initial differential diagnosis that I pointed out of a suppressed TSH. And based on the diagnosis, the treatment becomes different. Like in thyroiditis, you just need to give symptomatic treatment. 80% of cases, the patient will recover by herself. So you don't have to treat anything else. If it's an early disease, you need to give antithyroid medications like methimorphoxol. And if it's a toxic multinodular goiter, depending on the clinical scenarios and the patient picture, you may either choose for a methimorphoxol long-term antithyroid drug therapy in a low dose, or you may go for a surgery. If it's a toxic adenoma, the treatment would be radioactive iodine treatment. And also, if it's a drug-induced, you need to just identify and observe the disease. Lab issues like repeat testing, or lab issues, you may just treat it by repeat testing. So, depending on the diagnosis, the treatment may vary, and it may vary so and so that making a diagnosis is very important. So, in this patient, we just diagnose it as a early Graves with the typical picture, and we will go into the first patient. That's a typical patient. This is the problems in the evaluation problem. Then coming to the management issues, I'll go to the initial typical patient where the T3, T4 is very high and the TSH is suppressed. Then we can see that we'll start on methimorphoxol therapy and propranolol initially to control the heart rate. Then the management confusion comes in. So this patient you have started on antithyroid drugs, and then after 6 weeks, you are monitoring. Then the T3, T4 is reduced, TSH is still suppressed. The patient is having weight gain, goiter has reduced in size, pulse has normalized. Here what you should do? This is a common area of confusion. The patient has improved, T3, T4 is normal, clinically improved, but the TSH is still suppressed. What should you do? Should you continue with the same dose as the T3, T4 is normal, or should you increase the dose as the TSH is suppressed, or should you reduce the dose? What should you do? The ideal scenario, this is the time when you should reduce the dose. You shouldn't wait for the TSH to recover before reducing the dose. T3, T4 has normalized, the patient has clinically improved, you should start reducing the dose because it's a case of a Graves' disease. And then I asked the patient to come back after 3 months. Actually, she followed up after 6 months with again a report which says that T3 is normal range, T4 is normal range, and TSH has also recovered. Then what to do? Should we again continue with the same dose as the T3, T4 is normal, or stop treatment as the TSH is normal, or reduce the dose? Here again, that's a common mistake. You should not stop treatment when the TSH recovers. In thyroiditis, you stop treatment after the initial symptomatic phase because the patient has completely recovered. In Graves, ideally you should continue treatment for 1.5 to 2 years. So that's all. These all mistakes happen when you don't have a proper diagnosis initially in place. When you have a proper diagnosis, you can make it makes a lot of difference in the long-term management or the correct management of the patient. Because when the patient comes back, often the common question that happens if you're not done the initial diagnostic evaluation is that, am I dealing with a non-compliance? Am I dealing with a wrong diagnosis? Because you might have thought of a differential diagnosis, but the patient may not be responding in the same way as you expect. Then it becomes difficult. And also the questions that the patient asks. How long do we need to treat? How long should I take this medicine? Is it going to get cured by it, or I need to go for an iodine treatment or a surgery? So all these questions can be answered. And what is also the maintenance dose of methimorphoxol? What if the recurrence happens? What is the BRT? So those questions can be managed if you have a proper diagnosis in place. So some points you need to remember about managing hyperthyroidism is that diagnosis is very important to plan treatment. Don't be in a hurry to start the patient on antithyroid drugs. Always pinpoint the diagnosis, because whatever said and done clinically, like except for those few patients like the picture which I showed, it's most of the patients, the diagnosis may not be very straightforward. And I can tell you that at least 10-15% of the cases, even specialists make a wrong diagnosis from the clinical perspective. So always make sure that you have a proper diagnosis. TSH and technetium scan are the most important for the diagnosis. T4 is most important for monitoring and managing therapy in thyrotoxic. It's not TSH. We manage and monitor therapy based on T4 till the TSH recovers. Once the TSH recovers, then we follow up TSH. And treatment of hyperthyroidism is often tricky, and FNAC mostly is unindicated in a warm nodule. You don't need to, even if you see a nodule there in the warm nodule, you don't need to do an FNAC there. Thank you very much. That's it. Thank you, madam.
Thank you, Joe, for that excellent presentation. And the topic is open for discussion because he has finished well before the time. So we can have 1 or 2 questions.
25 minutes, madam.
Huh?
5 more minutes.
5 more minutes. 1 or 2 questions again. And I think I will ask something. So it's a very common problem. Most of the time we get abnormal thyroid function test. One of the value may be slightly abnormal. And the 2 situations is one preoperative patient, especially in emergency preparations and other things. They come with one thyroid function test, there will be some abnormality. And secondly, critically ill patients. So maybe you can just add on that.
Yes. Madam, yeah, these are very difficult areas. Like when a patient comes for a surgical fitness, first thing to consider is how emergency is the surgery. If it's a ruptured appendix, whatever may be the thyroid function, you just go for the surgery. So there is no need for fitness. You have to take whatever risk is there and then proceed with the surgery. The question comes only with the planned procedures, where it is usually said that if the free T3 and free T4 is normal, most of the time you wouldn't have any problem. And again, will you have problem? Even when the free T3, free T4 is normal, you can go for a thyroid storm, isn't it? Yes. Why? Because if it's like in this patient which I showed where the TSH is only mildly suppressed, the thyroid gland may have increased amount of hormone that is stored in the gland. So in those cases, that is an unprepared patient with a TSH that is suppressed, the gland may have an excess storage of hormones which can theoretically precipitate thyroid storm or crisis during surgery. But in a patient who is regular with treatment, who is on continuous treatment with antithyroid medication, even if it's a toxic MNG or a Graves' disease, within 6 weeks of time, the gland, though the TSH is suppressed, the gland gets depleted of that excess hormone store. So a patient totally unprepared, not on treatment, coming with a TSH suppressed, you have to proceed with surgery. If the free T3, free T4 is normal, the chance of storm is less, but it is still there. But if it's a regular patient who is on treatment with antithyroid medications for at least a period of 6 weeks, and then the T3, T4 is normal, usually the gland is depleted of hormones, though the TSH is suppressed. So there is no risk of taking that patient for surgery, provided that the T3, T4 is, or free T3, free T4 is in the normal range. That's about perioperative indication. Second thing is about the ICU. See, ICU, critical illness management, thyroid function, the first and foremost thing that the experts say is that unless there is a definite indication for doing a TFT, don't do it, because the result will confuse you more than before you have sent for the test. So unless there is a definite reason, like you feel that the patient is toxic, you feel that there is a component of hypothyroidism that is there, or like a ventilator-dependent patient where you feel that the thyroid is contributing, or the patient is already on treatment, don't do the test at the time of critical illness, just for the completion's sake, because that adds to the confusion, because non-thyroid illness syndrome can have all sorts of picture. Then you have to do it. Then sometimes it becomes difficult evaluating, but again you go by the pictures. Like a suppressed TSH with a normal free T3, free T4, most of the time you don't have to do anything. If it's an increased TSH, mild elevation of TSH, you don't have to do anything. Usually the common dictum is that in critical illness, T3 comes down first, T4 comes down, free T4 comes down next, and then TSH comes down last. And as you recover, TSH improves first, free T4 improves less, T3 improves last. So this pattern follows. So depending on the critical illness scenario, comparing with the scenario, you may have to take a decision.
Thank you, Joe. If there are no questions or comments, we will wind up the session. Over to the organizers. Thank you so much.
Request
Dr. Chandri, Chairperson, to hand over a memento to Dr. Jite. Session തന്നിട്ടല്ലേ? That is the last session of this CME program. Now I invite Dr. Raju C. Balram, President IMA Kozhikode, for the concluding remarks. Dr. Raju. I also invite all the organizing committee members, starting from Dr. V.G. Pradeep Kumar, Dr. Venugopal, Dr. Shankar, Dr. Chandni, Dr. Ranjit, Dr. Sandhya, Dr. Sapna, and all others to come forward for the valedictory function. Dr. Naufira, Dr. Laila B, Dr. Mohandas, Dr. Jidin, Dr. Anand, Dr. Ajida, Dr. Sapna, Dr. Nasser, Dr. Anil, Dr. Vimal Raju, for your concluding remarks.
Well, I start off by saying that this AMS conference has taken place during my presidency. Actually, this conference was supposed to take place in Dr. Venu's presidency. He did all the groundwork, all the hard work that you see today has been courtesy of Dr. Venugopalan B and his team. I do not take any credit for anything that you see here today. I'm just, by default, I happen to be standing here. And first of all, I want Venu, please come. Thank you so much. You have done a great job. I congratulate you and your team for the great show that you have put forward. Kindly accept this memento. ഒരു സ്ഥലത്തും നോക്കുമ്പം വേണുടെ പേരില്ല. The brainchild, മൂപ്പരുടെ പേര് എവിടെയുമില്ല. ഇന്നലെ നോക്കുമ്പോൾ പ്രോഗ്രാമിൽ where the award ceremony and all that.
I request Dr. V.G. Pradeep Kumar and Dr. Raju jointly handing over a moment to Dr. Venu. Thank you.
Then the chairman of this conference, the person who is one of the most resourceful persons in IMA Kozhikode, Dr. Pradeep Kumar VG, please accept this memento from us.
Actually, this was, as Dr. Raju mentioned, we were planning for September 24th, then got postponed. And that had some hiccups in between. But I'm happy that the PG presentation as well as award paper presentation came up well, even though in a short notice, and they were of good qualities. And the award paper, number of PG presentation, the award paper presentation, that is only promising thing. And I think we should have more of publications as well as such platforms for the youngsters to present. And this was entirely a teamwork, and the credit goes to all of us. I think, Dr. Roy, you should come forward. You are also part of the team. And we all should work together for the betterment of the profession, organization, as well as for the society. That's all I have to say, and kudos to the entire team who has worked as a family. Thank you.
Thank you, Pradeep. So kindly accept this memento from the treasurer, the secretary and myself. And behind every successful man, there is usually a lady, and that is the secretary of the former secretary of IMA Kozhikode, Dr. Sandhya. Please come forward. ഒരുപാട് പറയരുത്. No, നിന്റെ ശബ്ദം കേട്ടേ പറ്റൂ.
ഒന്നുമില്ല, അധികം പറയുന്നില്ല. എന്തായാലും ഡോക്ടർ വേണുവിൻ്റെ ആ ടീമിലാണ്, ആ ടൈമിലാണ് നമ്മളിത് ഏറ്റെടുത്തത്. എന്തായാലും ഒരു സങ്കടമുണ്ട്, ഉള്ളിലൊരു ചെറിയ സങ്കടമുണ്ട്. നിപ്പ വന്നതുകൊണ്ട് പോസ്റ്റ്പോൺ ചെയ്യേണ്ടി വന്നു. എന്തായാലും ഇപ്പോഴത്തെ ടീം അത് വളരെ ഭംഗിയായിട്ട് അത് ചെയ്തിട്ടുണ്ട്. നമ്മൾക്കും അതിൻ്റെ ഭാഗമാകാൻ പറ്റിയിട്ടുണ്ട്. ഇവിടെ എത്തിച്ചേർന്നിട്ടുള്ള എല്ലാവർക്കും താങ്ക്സ് പറയാണ്. പിന്നെ നമ്മുടെ ടീമിന് എന്തായാലും ഇനിയും ഇത്തരം പ്രോഗ്രാംസ് നല്ല രീതിയിൽ ഒന്നും കൂടി നന്നാക്കിയിട്ട് നമുക്ക് ചെയ്യാൻ പറ്റട്ടെ. താങ്ക് യു.
Please accept this memento from us. Every conference has got a chairman, and then the chairman has got a secretary. Shankar Mahadevan. Shankar, you have been the nerve center for this particular conference. Thank you so much for all the efforts that you have put on. You have brought a lot of glory to IMA Kozhikode. Please accept this memento. Scientific committee was handled by Chandani madam. You have received a lot of mementos. You don't want any more. All right.
The PG presentation also spearheaded.
The PG presentations, you handled it very well, and you did a great job.
Now I request Dr. Ranjit to tell the results, to declare the results of PG presentation.
There was a good participation from all the PGs. There was 9 presenters, and first prize goes to Dr. Chitralega. And
Chitralega, please come forward.
Certificate as well as a cash award. I request Dr. Pradeep to hand over the certificate and Dr. Venugopal to hand over the cash prize.
second prize goes to Dr. Anjana Sandosh.
I request to Dr. Raju Balram to hand over the certificate and Dr. Shankar to hand over the cash award.
Third prize was shared by Dr. Rahul Das and Dr. Hari Krishnan. I request Dr. Rahul Das to come first.
I request Dr. Chandani to hand over the certificate to Rahul and Dr. Sandhya to hand over the cash award. Dr. Hari, I request Dr. Laila B to hand over the certificate and Dr. Sapna to hand over the cash prize. സന്ധ്യ പറഞ്ഞു ലൈലാബി.
Dr. Lailabi, please accept this memento from IMA Kozhikode.
The past
IMAs.
Actually, the
Actually,
conference.
you were supposed to be in the helm of affairs.
Raju.
Dr. Lailabi excellently organized a research methodology workshop, and we should all congratulate her. She single-handedly coordinated the people and selected the topics, and definitely fitting to the community medicine department. Thank you.
Next, Ranjit.
Dr. Ranjit, you have ably assisted Lailabi Madam in this conference. Thank you so much. Please accept this memento.
Ranjit also did a great work in PG presentation by sorting out all and collecting it, communicating with them.
Dr. Naufira.
പുറകിലുണ്ട്.
Thank you so much for all the efforts that you have put for this conference.
അടുത്ത ആളെ വിളി. ഞാൻ വിളിക്കാം. ഡോക്ടർ രഞ്ജിത്ത് തന്നു. ഓക്കെ. ഡോക്ടർ മോഹൻദാസ്, ഡോക്ടർ ജിതിൻ, ഡോക്ടർ ധന്യയിലല്ല, ഡോക്ടർ ആനന്ദ്, ഡോക്ടർ അജിത, ഡോക്ടർ സപ്ന,
Dr. Sapna was the past chairperson of WW. She was actively involved in organizing things, receiving people and arranging. Thank you, ma'am.
ഡോക്ടർ നാസർ, ഡോക്ടർ വിമൽ രാജ്, അത് കുഴപ്പമില്ല, ഡോക്ടർ അനിൽ, അനിൽ. പിന്നെ നമ്മുടെ IMAയിൽ എന്തുണ്ടെങ്കിലും നമ്മളെല്ലാവരും വിളിക്കുക ബിജുവിനോട് പറയാമെന്നാണ്. അപ്പോൾ ബിജു ഈസ് ദി ഓൾ ഇൻ ഓൾ, അല്ലെ, ഓൾ റൗണ്ടർ ഇൻ ദി IMA ഇൻ എവറി പ്രോഗ്രാം. I request Biju to receive a memento from our Dr. Raju as well as from Dr. Pradeep Kumar. So now the accounts in the IMA is managed by Sandosh. പിന്നെ ഇടയ്ക്കിടയ്ക്ക് സന്തോഷം ബേജാറാക്കും, പൈസയൊന്നും വന്നില്ല എന്ന് പറഞ്ഞിട്ട്. പക്ഷേ അവസാനം അത് VGയുടെ ഒരു വലിയ എഫേർട്ടാണ്, ഇതിലെ ഒരു സ്പോൺസർഷിപ്പ്. അതിനൊരു പ്രത്യേക നന്ദി പറയുന്നു. കാരണം കോൺഫറൻസ് ലാഭകരമാവുക എന്നുള്ളത് ഇല്ലെങ്കിലും നഷ്ടത്തിലാവരുത്. അത് നഷ്ടത്തിലായില്ല എന്ന് ഏകദേശം ഉറപ്പാണ്. അത് VGയുടെ ഒരു റോളുണ്ട്. അതുപോലെ തന്നെ actually the organizing committee headed by Dr. VG Pradeep Kumar, ably supported by Shankar, run this show. As Dr. Raju mentioned, the IMA year is from October 1st to September 30. By default, it was shifted to this month because of the Nipah. Even though the immediate past president, Dr. Venugopal, acted like a president, it's ഒരിക്കലും ഒരടി പോലും അന്നത്തെ റോളിൽ നിന്ന് പിന്നോട്ട് പോയിട്ടില്ല, മുന്നോട്ടേക്കാണ് വന്നത്. പക്ഷെ അതൊരു വലിയ ഒരു എക്സാമ്പിളാണ്. നമ്മൾ പലപ്പോഴും അങ്ങനെ ചെയ്യില്ല, അല്ലേ? ഇനിയിപ്പോൾ എന്തെങ്കിലും ആയിക്കോട്ടെ എന്ന് ചിലപ്പോൾ വിചാരിച്ച് പോകും. പക്ഷേ വേണു നെവർ തോട്ട് ദാറ്റ്. ഇടയ്ക്ക് നമ്മൾ അടിയൊക്കെ ഉണ്ടാക്കും, പക്ഷേ അതൊരു സ്പോർട്സ്മാൻ സ്പിരിറ്റ് തന്നെയായിരുന്നു ശരിക്കും. അപ്പോൾ ഇതൊന്നും കൂടി പറയാണ്. ഐ ഹാൻഡ് ഔട്ട് ടു സന്തോഷ്. അതുപോലെ തന്നെ സന്ധ്യയായിരുന്നു ഇത് പറയേണ്ടിയിരുന്നത്, പക്ഷേ അതങ്ങനെ ചില നിമിത്തങ്ങളാണ്, അത് മാറി വന്നു, അത്രയേ ഉള്ളൂ. ഓക്കെ. അപ്പോൾ ഒരു ഫൈനൽ റിമാർക്സിന് നമ്മുടെ ശങ്കറിനെ വിളിക്കുന്നു.
കൺക്ലൂഡിങ് റിമാർക്സ് പറയാൻ വേണ്ടിയിട്ടാണ് എന്നോട് പറഞ്ഞിരിക്കുന്നത്. അപ്പം പല കാരണങ്ങളാൽ മാറ്റിവെക്കപ്പെട്ട ഒരു കോൺഫറൻസിൻ്റെ പുനരവതരണമാണ് കഴിഞ്ഞ 2 ദിവസമായിട്ട് കണ്ടത്. ഹിമാചലിൽ നിന്ന് കേരളത്തിലോട്ട് വന്ന് കേരളത്തിൻ്റെ തെക്കേ അറ്റമായ തിരുവനന്തപുരത്ത് നിന്നും വടക്കേ അറ്റമായ കോഴിക്കോടിലേക്ക് തട്ടിയിട്ട് അത് കോഴിക്കോടുകാരുടെ നിർഭാഗ്യം കൊണ്ടോ എന്താണെന്നറിയില്ല, നിപ്പ കാരണം വീണ്ടും മാറിപ്പോയി. കഴിഞ്ഞ 2 ദിവസത്തേക്ക് ഉള്ള ഒക്ടോബർ 27, 28 അത് നടക്കുമോ നടക്കില്ലയോ എന്നുള്ള കഴിഞ്ഞൊരു 3 ആഴ്ച വരെ വളരെ കൺഫ്യൂഷൻസ് ഇതിൻ്റെ പിന്നിലുണ്ടായിരുന്നു. കൺഫ്യൂഷൻസ് വരാൻ കാര്യം മാത്രമൊന്നുമല്ല, കാരണം നമ്മുടെ IMA ഇയർ കഴിയാൻ പോവുകയാണ്. അപ്പോൾ IMA ഇയർ കഴിയാൻ പോകുമ്പോഴത്തെ സ്റ്റേറ്റ് വൈഡ് ആയിട്ടുള്ള ഒരുപാട് പരിപാടികൾ നടക്കുന്നുണ്ട്. എല്ലാ വീക്കെൻഡ്സും സാറ്റർഡേ സൺഡേ എവിടെയെങ്കിലും വെച്ച് പ്രോഗ്രാംസാണ്. അപ്പോൾ സ്റ്റേറ്റ് പ്രസിഡൻറ്റും സെക്രട്ടറിയും ഫ്രീ അല്ല. നാഷണൽ പ്രസിഡൻറ്റ് ഡിസംബറോടുകൂടി നാഷണൽ IMA ഇയറും കഴിയാൻ പോവുകയാണ്. അപ്പോൾ അവിടെയും ഓട്ടമാണ്. അപ്പോൾ ഇവരെയൊക്കെ എല്ലാവരെയും കൂടെ ഒന്നിച്ച് കിട്ടാൻ പറ്റുന്ന ഒരു അവസരം ഉണ്ടാകുന്നില്ല എന്നുള്ളതായിരുന്നു പ്രധാനം. അതുകൊണ്ടാണ് ഞായറാഴ്ച ദിവസം കോൺഫറൻസ് വെക്കാൻ സാധിക്കാതെ വന്നതും വെള്ളി ശനി ദിവസങ്ങളിലായിട്ട് കോൺഫറൻസ് ക്രമീകരിക്കാൻ തീരുമാനിച്ചതും. വർക്കിംഗ് ഡേ ആയിട്ട് പോലും നമുക്ക് ഈ രീതിയിൽ ഒന്ന് ഷെഡ്യൂൾ ചെയ്യുകയും ഫോർനൂൺ സെഷൻ ആദ്യത്തെ ദിവസം കുറച്ച് വർക്ക്ഷോപ്പുകളും ഉച്ച കഴിഞ്ഞിട്ട് നമുക്ക് അക്കാഡമിക് സെഷൻസും എന്ന രീതിയിൽ ഒരു അവസാനം നമ്മൾ കൺക്ലൂഡ് ചെയ്യേണ്ടത്, കാരണം കുറച്ചുകൂടെ ആളുകളെ കിട്ടും എന്നുള്ളതുകൊണ്ട്. അങ്ങനെ ഫ്രൈഡേ സാറ്റർഡേ ആയിട്ട് ഈ വർക്ക്ഷോപ്പ് നടത്തപ്പെടുകയുണ്ടായി. പക്ഷേ എന്നിരുന്നാലും ഒരുവിധം എല്ലാ ഇടത്തു നിന്നും ആവശ്യത്തിനുള്ള സപ്പോർട്ട് നമുക്ക് വേണ്ടി ലഭിച്ചു. അത് ഈ പറഞ്ഞ പോലെ ഒരു IMA ഇയർ കഴിയുക എന്ന് പറയുമ്പോൾ ഇതൊരു നോമാൻസ് ടെറിട്ടറിയാണ്. കഴിഞ്ഞതിട്ട് കഴിഞ്ഞും പോയി, പുതിയ ആൾക്കാരിട്ട് രംഗപ്രവേശം ചെയ്തുമില്ല, പ്രോപ്പറായിട്ട് അവർക്ക് അതിൻ്റെ ഒരു IMA ഒരു ഇതിലോട്ട് വന്നുമില്ല അവർ എന്നുള്ള ഒരു സമയത്താണ് നമ്മുടെ ഈ കോൺഫറൻസിൻ്റെ ഒരു സ്കെഡ്യൂൾ, ഒരു ഡേറ്റ്സ് ഫിക്സ് ചെയ്യപ്പെടുന്നത്. പക്ഷേ നമ്മളുടെ ഒരു ഭാഗ്യം കൊണ്ട് ഏതായാലും 2 കൂട്ടരും, പോയവരും വേണു സന്ധ്യ ആയാലും വന്നവർ രാജുവും അഷ്റഫ് സാറും ആയാലും എല്ലാവരും നമ്മുടെ കൂടെ തന്നെ നിന്നു. അപ്പോൾ ഒരുവിധം നമുക്കുള്ള അതിനുള്ള ഒരു കരുത്ത്, വളരെ നല്ല രീതിയിലുള്ളൊരു സപ്പോർട്ട് ഈ 2 കമ്മിറ്റികളിൽ നിന്നും കഴിഞ്ഞ കൊല്ലത്തെയും ഇക്കൊല്ലത്തെയും നമുക്ക് ലഭിക്കുകയുണ്ടായി. അതുപോലെ തന്നെ ഇതിൻ്റെ ഏറ്റവും വലിയ ഒരു പവർ ബാങ്ക് ഏത് കോൺഫറൻസിൻ്റെയും എന്ന് പറയുന്നത്, ഒന്ന് ഇതിൻ്റെ നഷ്ടമായി പോയാൽ പരിപാടി അവതരിപ്പിച്ച് എവിടെ പരിപാടി അവതരിപ്പിച്ചാലും പൊളിയാണല്ലോ എന്നുള്ളൊരു ഇത് വരുമല്ലോ. പക്ഷേ IMAക്ക് അങ്ങനെ തീരുമാനിക്കേണ്ടി വന്നില്ല. കാരണം അത്യാവശ്യം ഡെലിഗേറ്റ്സ് ഉണ്ടായിരുന്നു. ഓൺലൈനിൽ നമുക്കൊരു 200ഓളം രജിസ്ട്രേഷൻസ് നമുക്ക് ലഭിച്ചു. കാരണം ഇത്രയും നേരം ഓൺലൈനിലും രജിസ്ട്രേഷൻസ് കണ്ടിന്യൂ ചെയ്തുകൊണ്ടിരുന്നു ഇന്നലെ മുതൽ. അത് തമിഴ്നാട്, കർണാടകം, നോർത്ത് ഇന്ത്യയിൽ നിന്നൊക്കെ നമുക്ക് ആളുകൾ ഡെലിഗേറ്റ്സ് ഓൺലൈനിൽ കാണുന്നുണ്ടായിരുന്നു എന്നുള്ളതാണ്. അപ്പം 2 ദിവസം വന്ന പരിപാടിയൊക്കെ കണ്ട് ആസ്വദിച്ച് നിന്ന എല്ലാവരോടും നമ്മൾ ഓർഗനൈസിങ് കമ്മിറ്റീൻ്റെ പേരിൽ, ഓർഗനൈസിങ് സെക്രട്ടറി എന്ന വകയിലും കോഴിക്കോട് IMAയുടെ പേരിലും എല്ലാവരോടും നന്ദി രേഖപ്പെടുത്തുകയാണ്. എല്ലാവർക്കും നന്ദി, നമസ്കാരം. ഇനി അടുത്ത നമ്മുടെ സ്റ്റേറ്റ് കോൺഫറൻസ് വരുന്നു തിരുവല്ലയിൽ. അത് കഴിഞ്ഞ് തിരുവനന്തപുരത്തുകാർ റെഡിയായി നിൽക്കുന്നുണ്ട് നാഷണൽ കോൺഫറൻസ് ഗംഭീരമാക്കാൻ വേണ്ടിയിട്ട്. ജയ് IMA, ജയ് ഭാരത്.
Ladies and gentlemen, please a standing ovation to this team.
One minute. നമ്മൾ പലപ്പോഴും ഏറ്റവും അടുത്ത ആളുകളെ മറന്നു പോകും. അപ്പോൾ ഡോക്ടർ രാജു വാസ് സൈലൻ്റ്ലി വർക്കിംഗ് ബിഹൈൻഡ് ഓൾ ദിസ് സീൻ. ഐ റിക്വസ്റ്റ് ഡോക്ടർ VGP Deepkumar to hand over a memento to Dr. Raj.
നമുക്ക് എല്ലാവർക്കും കൂടി ഒരു ഫോട്ടോ എടുക്കാൻ മുമ്പ് നാഷണൽ ആന്തം എന്തായാലും കൺക്ലൂഡ് ചെയ്ത് ആഫ്റ്റർ ദാറ്റ് വിൽ ഹാവ് എ ഫോട്ടോ സെഷൻ ഹിയർ.
നമ്മൾ 2 ദിവസമായിട്ട് വിനുവിൻ്റെ നേതൃത്വത്തിലുള്ള ഫോട്ടോഗ്രാഫേഴ്സ് ഇവിടെയൊക്കെ ഉണ്ടായിരുന്നു. അവർക്കൊരു പ്രത്യേക നന്ദി പറയുന്നു. അതുപോലെ തന്നെ പ്രസ്സിനും സൗണ്ടിനും താജ് ഇതിൻ്റെ താജ് എന്തായിരുന്നു, ഗേറ്റ് വേ ഹോട്ടലിനും ഓഡിയോ വിഷ്വൽ ടീമിനും സ്പോൺസേഴ്സിനും പ്രസ്സിനും നിങ്ങൾക്കെല്ലാവർക്കും കോഴിക്കോട് IMAയുടെയും ഓർഗനൈസിംഗ് കമ്മിറ്റിയുടെയും പേരിൽ ഹൃദയം നിറഞ്ഞ നന്ദി.
നാഷണൽ ആന്തം പ്ലീസ്.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Please join for the organizing committee, join for the photographs.